So diabetes mellitus, our new topic. To understand diabetes mellitus, first we should know the basic concept of insulin. How insulin is secreted. Okay. So now first I will tell you the basic concept of insulin. All of you know insulin is secreted by beta cells. These beta cells they are present in islets of Langerhans. And these islets of Langerhans they are present in pancreas. Okay. So now suppose this is pancreas. In pancreas there are small group of cells. These blue dots, these are islets of Langerhans. Islets of Langerhans they are scattered everywhere in pancreas, and maximum concentration of islets of Langerhans it is present in tail of pancreas. Now we will take section of this pancreas, and specially we are interested in these islets of Langerhans. So suppose this is islet of Langerhans. I have taken section through this, and in islets I will get three cells: alpha cell, beta cell and delta cell. Alpha, beta and delta. Alpha cell secrete glucagon. Beta cell secrete insulin. And delta cell it secretes somatostatin. Now you should know the relation of alpha, beta and delta. Alpha cells they secrete glucagon and alpha cells stimulate both. Alpha cell stimulate both. Okay, alpha cell stimulate beta cell and delta cell, while beta cell and delta cells both they inhibit alpha cell. Beta cell and delta cell both they will inhibit alpha cell, and delta cells they secrete somatostatin and they inhibit both beta cell and alpha cell. Okay, so now how to remember this? To remember this I have a simple mnemonic: A for alpha. A for alpha, in Hindi we say acha. Just remember, A for alpha, A for acha. Acha means good people. Alpha are good people. Good people always stimulate others. So alpha stimulate beta and delta. But problem is that good people are always inhibited by others. Okay. So alpha cells are inhibited by beta and delta. D for delta, D for dawn. And dawn always inhibits other. Dawn always inhibits other, and no one can inhibit dawn. Now, after understanding this, we will see the exact mechanism of secretion of insulin. To understand the exact mechanism of secretion of insulin, we will draw a very big beta cell. Suppose this is beta cell. This is blood vessel. Okay. Now, after eating food, glucose, after eating food, glucose will enter in blood. This is glucose in blood. And Our beta cells of islets of Langerhans, they are having GLUT2 transporters. This is GLUT2 transporters. These GLUT2 transporters, they will transport the glucose. GLUT2 transporters, they will transport the glucose. And property of GLUT2 transporter, it is GLUT2 transporters, they will transport the glucose from high concentration to low concentration. So when glucose in blood increases, they will transport glucose from blood to beta cell. So glucose from blood, it will enter in beta cell. But if glucose in beta cell increases, then GLUT2 transporters can transport the glucose from beta cell to blood. Okay, so simply we have to remember GLUT2 transporters transport glucose from high concentration to low concentration. Now, once this glucose enters in beta cell, this glucose is converted to glucose 6-phosphate. This glucose is converted to glucose 6-phosphate by the enzyme glucokinase or hexokinase. And now, what is the importance of conversion of glucose to glucose 6-phosphate? Once this glucose is converted to glucose 6-phosphate, then this glucose is locked inside the beta cell. Means now this glucose 6-phosphate is cannot be transported to blood by GLUT2 transporters. Simply, GLUT2 transporters cannot transport glucose 6-phosphate, but GLUT2 transporters can transport glucose. Glucose 6-phosphate. Now this glucose 6-phosphate, it will undergo glycolysis and it will form pyruvic acid. This pyruvic acid, it will enter in mitochondria. This pyruvic acid, it will enter in mitochondria, and in mitochondria Krebs cycle is going on. Krebs cycle or TCA cycle. Okay, and with the help of this Krebs cycle, pyruvic acid, it will convert ADP into ATP, ADP into ATP. Okay, so simply when glucose increases in blood, it is transported to beta cell. Glucose is converted to glucose 6-phosphate. Then glucose 6-phosphate undergoes glycolysis. It is converted to pyruvic acid. Pyruvic acid enters in Krebs cycle in mitochondria, and mitochondria will convert ADP into ATP. Okay, now this is part 1 of the story. Now we will see part 2 of the story. Okay, our beta cells, they are having some calcium channels. Beta cells are having calcium channels. These calcium channels, they are called as voltage gated calcium channels. Voltage gated calcium channels, because opening of calcium channels depends on voltage. When positive charge increases in beta cell, then calcium channels will open. When positive charge increases in beta cells, calcium channels will open. Okay, so these channels are closed. These channels are closed. These channels are closed, and when positive charge in beta cell increases, then it will cause opening of calcium channels. Then beta cells, they are having potassium channels. Beta cells, they are having potassium channels, and these potassium channels, they are transferring potassium from beta cell to outside the cell. Normally, potassium channels are present on beta cells, and they are transferring potassium from beta cell to outside the beta cells. Now, next important thing, normally ADP, they are present on potassium channels. ADP are present on potassium channels, okay, and when ADPs are present on potassium channels, they will cause, then potassium channels will remain open. When ADP are present on potassium channels will remain open. Okay, now we will connect part 1 of the story with part 2 of the story. Okay, what was the part 1? Glucose enters in beta cell, glucose converted to glucose 6-phosphate, and it undergoes glycolysis and it forms pyruvic acid. Okay, and pyruvic acid is used for conversion of ADP to ATP. So now after taking food, glucose increases and it will stimulate Krebs cycle. So demand of ADP will increase, and when demand of ADP increases, then ADPs of potassium channels, they will be transferred to Krebs cycle. ADPs of potassium channels, they will be transferred to Krebs cycle, and the ADPs, they will be converted to ATPs. Now these ATPs, they will be transferred back to potassium channels, and these ATPs, they will block the potassium channels. These ATPs, they will block the potassium channels, and when potassium channels are blocked, then potassium will increase inside the beta cell, and it will increase the positive charge inside the beta cell. Okay, and when positive charge increases in beta cell, calcium channels in beta cells, they will open. So ATPs are responsible for blocking of potassium channels. So these potassium channels are called as ATP sensitive potassium channels. Potassium channels are called as ATP sensitive potassium channels. Okay, once potassium channels are blocked, potassium will remain inside, so positive charge in beta cell will increase, and when positive charge in beta cell increases, it will cause opening of calcium channels, so calcium will enter in beta cell. Now our beta cells, they are having lot of vesicles. Our beta cells are having lot of vesicles, and these vesicles, they are storing insulin. These vesicles, they are storing insulin, and whenever insulin is synthesized in our body, it is synthesized with C-peptide. Actually, C-peptide, it is a part of precursor of insulin. During synthesis of insulin, C-peptide is separated from the insulin, but it is stored with insulin. Okay, so now we are having insulin vesicles present in beta cells, and calcium is responsible for release of these vesicles. Calcium is responsible for release of these vesicles, and from these vesicles now insulin will be released with C-peptide. Insulin will be released with C-peptide. Okay, So whenever insulin is secreted from beta cell, it is secreted with C-peptide. So in blood, insulin increases with C-peptide. Okay. So this is the mechanism of secretion of insulin. Now what is the importance of this mechanism? What is the importance of this mechanism? In MCQ exam, they will give you that patient is having hypoglycemia, sugar levels are decreased, and on blood investigations you are getting insulin is increased but C-peptide is decreased. In MCQ exam, they will give you insulin is increased with C-peptide is decreased. It means this insulin is not coming from the beta cell, this insulin is coming from outside the body, so it is exogenous insulin. And if they are giving you that patient is having hypoglycemia, insulin is increased with C-peptide, it means patient is having increased endogenous secretion of insulin. It means patient may have a tumor called as insulinoma, which is secreting lot of insulin. Or second possibility, patient has taken any drug like sulfonylurea, which can cause increase in secretion of insulin by beta cells. Okay, so next practical important point. Suppose suppose I have a drug which can block potassium channels. Suppose if I have a drug which can block potassium channels, then what will happen? If patient has taken a drug which can block potassium channels, then potassium will remain in the beta cell. If potassium remains in beta cell, positive charge will increase. If positive charge increases, lot of calcium it will enter in beta cell and it will cause release of insulin. So the drug which is blocking potassium channels, it will increase insulin secretion. And opposite of this, suppose if I have a drug which can open blocked potassium channels, if I have a drug which can open potassium channels, then these potassium channels they will remain open, positive charge will go outside and positive charge in beta cell will decrease, calcium channels will not open and insulin secretion will decrease, and these drugs are used in a tumor called as insulinoma. So the drug which are acting on potassium channels of beta cells. Drugs acting on potassium channels of beta cells. The drug which can block potassium channels and drugs which can open potassium channels. Drugs which can block potassium channels, they will increase insulin secretion from beta cell. And example of this is sulfonylureas and megelandronate. And drugs which can open potassium channels, they will decrease insulin secretion. They will decrease insulin secretion. And these drugs, they are used in insulinoma. Name of the drug is diazoxide. Name of the drug is diazoxide. Suppose if patient is having glucokinase deficiency or hexokinase deficiency, then glucose cannot be converted to glucose 6-phosphate or amount will be decreased. So glucose will increase in beta cell and this glucose it will be transferred to blood. So patient will have hyperglycemia in blood. Then glycolysis will decrease, synthesis of pyruvic acid will decrease, so synthesis of ATPs will decrease and secretion of insulin it will also decrease. So patient will have hyperglycemia because of decrease in insulin secretion and it is because of defect in a beta cell, and it is called as maturity onset diabetes of young, MODY. Maturity onset diabetes of young. What is maturity onset diabetes of young? When patient is having hyperglycemia due to defect in a beta cell. When patient is having hyperglycemia because of a defect in beta cell. It is called as MODY. Now, there are total 6 different types of MODY. Means there are total 6 different types of defects in beta cell. According to each defect, there is a different type of maturity onset diabetes of young. So now we will see type of MODY, type of maturity onset diabetes of young, and various defects. All these defects, they are present in beta cell. So first one, type MODY type 1. Patient is having defect in HNF4 alpha. HNF4 alpha. HNF means hepatocyte nuclear transcription factor. Hepatocyte nuclear transcription factor alpha 4 alpha. HNF4 alpha. MODY type 2. Glucokinase deficiency. Just we have seen glucokinase deficiency. MODY type 3, it is most common type of MODY. MODY type 3, it is most common type of MODY. Defect is in HNF1 alpha. Then 4, insulin promoter factor 1. Insulin promoter factor 1. Fifth one, HNF1 beta. HNF1 beta. And sixth, NeuroD1. Okay, so these are the total 6 types of maturity onset diabetes of young, and all these defects are present in beta cells. Your MCQ, most common type of MODY is MODY type 3. Then maturity onset diabetes of young, it is autosomal condition. It is autosomal dominant condition. This is AD, autosomal dominant condition. Generally, age of the patient is less than 25 years. Age of the patient is less than 25 years. And in this disease, we have to give a drug which can stimulate beta cell to secrete insulin. So we use the drug, oral hypoglycemic drugs like sulfonylureas, which can stimulate beta cells to secrete insulin. This is maturity onset diabetes of young. Now, types of diabetes. Now give the heading, types of diabetes. There are mainly 2 types of diabetes, type 1 diabetes and type 2 diabetes. Type 1 diabetes and type 2 diabetes. First we will see type 1 diabetes. In type 1 diabetes, there is autoimmune destruction of beta cells. Autoimmune destruction of beta cells. A lot of antibodies are discovered. These antibodies are destroying the beta cells. So number of beta cells will decrease. When number of beta cell decreases, insulin concentration, insulin secretion, it will automatically decrease, and patient will have severe deficiency of insulin. Now for exam, what is important for us? Name of antibodies which are responsible for type 1 diabetes. Lot of antibodies are present. On internet you will get number of antibodies. But which antibodies are important? The antibodies which are given in Harrison. So we will write only antibodies which are given in Harrison. So antibodies given in Harrison, they are islet cell antibodies. Islet cell antibodies. They are GAD65, full form glutamic acid decarboxylase. Glutamic acid decarboxylase. Glutamic acid decarboxylase. These antibodies are the antibodies which are commercially available in lab. These are the only antibodies which are commercially available in lab. Other antibodies are antibodies against insulin. Then IA2, ICA 512, ZNT8. Then chromosome number 6 is associated with type 1 diabetes. Chromosome number 6 is associated with type 1 diabetes. Clinical features. Generally, these patients are thin. Age of onset is less than 30 years. Generally, age of onset is less than 30 years, but remember, it is not the rule. It is not the rule. Type 1 diabetes can occur after 30 years of age. According to Harrison, 5 to 10% patients, they will diagnose as a type 1 they will be diagnosed as a type 1 diabetes after 30 years of age. Okay, so type 1 diabetes, generally age group less than 30 years, but in 5 to 10% of the patients it occurs after 30 years of age. So please remember, age is not the criteria to diagnose a patient as a type 1 or type 2 diabetes. Now, these patients are having high risk for diabetic ketoacidosis. Diabetic ketoacidosis. We will discuss this in diabetic ketoacidosis. Okay, these patients are having very high risk of diabetic ketoacidosis because these patients are having very severe insulin deficiency. Then treatment is insulin. These patients are having very severe deficiency of insulin, so treatment is insulin, injections of insulin. Now type 2 diabetes. Type 2 diabetes, it is because of increased peripheral resistance to insulin. Okay. Now what is meaning of increased peripheral resistance? Suppose this is a cell. This is our normal cell and only 2 units of insulin is required to perform the normal action of this cell. Just imagine a normal cell requires 2 units of insulin to perform its normal function. Okay. Now when I am saying there is increased peripheral resistance, it means the same cell is now demanding 10 units of insulin. Same cell is demanding 10 units of insulin to perform the same action, to perform the same function. So I can say there is increased resistance to the insulin or decreased sensitivity to insulin. Because of this, there is increased demand of insulin. Because of this patient will have increased demand of insulin. Because of increased demand of insulin, workload on beta cell it will increase. Number of beta cells they are normal, but workload on beta cell is increased. So beta cells they are trying to synthesize more amount of insulin and patient enters in a stage called as hyperinsulinemia. Hyperinsulinemia. So insulin concentration it will increase in blood, but this insulin is not sufficient because patient is having increased resistance to insulin. So we have to increase the secretion of insulin or we have to decrease the glucose in blood. So we use here oral drugs. We use oral drugs. The drugs which will help beta cell to secrete more amount of insulin or drugs which can increase sensitivity to insulin. We are also having drugs which will decrease glucose concentration in blood by inhibiting gluconeogenesis or by inhibiting glycogenolysis. There are some drugs which can inhibit the intestinal absorption of glucose or drugs which can excrete the glucose. So we are having lot of oral drugs with different mechanisms of action. These drugs they will help beta cell to secrete more amount of insulin or decrease the glucose concentration in blood. Okay. Now because of age, as age of the patient is increasing, the peripheral resistance to insulin it also increases. So as age of the patient increases, resistance to insulin it also increases. So workload on beta cell it will also increase. So as workload on beta cell is increasing, now the destruction of beta cell will start. And when beta cell destruction start, when beta cell destruction starts, number of beta cells will decrease, and when number of beta cell decreases, now insulin concentration will decrease. Insulin concentration will decrease, and here we have to give injections of insulin because oral drugs now they will not work. So the person who was responding to oral drugs previously, now he will come to you with uncontrolled sugar despite of taking the drugs. So now we have to start insulin. Okay. So both diabetes, type 1 diabetes and type 2 diabetes, both are insulin dependent diabetes. The old terms, old terminologies like insulin dependent diabetes, non-insulin dependent diabetes, now these terms are obsoleted. Now we are not using these terms. Now we are using type 1 diabetes where antibodies are destroying the beta cell. Type 2 diabetes where there is increased resistance to insulin, and third maturity onset diabetes of young in which there is a defect in a beta cell leading to hyperglycemia. Okay. Now clinical features of these patients in type 2 diabetes, generally these patients are obese. Generally, these patients are obese, they are having hypertension, and age of the patient is more than 40 years. So generally, these patients are obese, hypertension, they are having hypertension, and age is generally more than 40 years. And in treatment, generally first we give oral drugs and then we will shift to insulin. Okay, this is type 2 diabetes. Now, criteria for diagnosis of diabetes. Criteria for diagnosis of diabetes. If patient is having symptoms of diabetes, if patient is having symptoms of diabetes and with symptoms random blood sugar level, if random blood sugar level more than 200 milligram per dl, if patient is having symptoms of diabetes and random blood sugar level more than 200 milligram per dl, it is a case of diabetes. Okay. Now what are the symptoms of diabetes? Symptoms of diabetes are polyuria, polyphagia, polydipsia and weight loss. Mainly polyuria, polydipsia and weight loss. Okay. Now why weight loss occurs in diabetes? Because in diabetes glucose is increasing in blood, but this glucose is not able to enter in cell, so cells they are not able to use the glucose, so cells they are not able to produce ATPs from the glucose. So these cells they will utilize the lipid, fats, or these cells will utilize the proteins, amino acid for production of energy. That's why patient will have weight loss. So diabetes causes weight loss, but obesity increases the risk of diabetes because obesity increases peripheral resistance to insulin. So please remember this. Obesity increases the risk of diabetes, but diabetes itself it is a cause of weight loss. Now, second, fasting blood sugar level. Fasting blood sugar, if it is more than 126 milligram per dl, fasting blood sugar more than 126 milligram per dl, fasting for at least 8 hours. Patient will come in the morning with fasting of 8 hours, then we will collect the blood and we will collect the sugar. If it is more than 126 milligram per dl, your patient is having diabetes. Next, HbA1c. If HbA1c is more than 6.5%, what is HbA1c? It is glycated or glycosylated hemoglobin. When glucose increases in blood, this increasing glucose, it will combine with hemoglobin. Increasing glucose, it will combine with hemoglobin. It will form glycated hemoglobin. It is called as HbA1c. If it is more than 6.5, then patient is a case of diabetes. Fourth one, 2-hour plasma glucose. 2-hour plasma glucose more than 200 milligram per dl. 2-hour plasma glucose more than 200 milligram per dl during an oral glucose tolerance test. During an oral glucose tolerance test. How to do a oral glucose tolerance test? First, patient will come to you in the morning and Patient will come to you. Patient will come to you early in the morning with 8-hour fasting. We will collect the blood sample. It is fasting blood sugar. After this, we will give 75 gram of anhydrous glucose. Patient will take that glucose, 75 gram of anhydrous glucose. After giving that glucose, we will ask the patient to wait for 2 hours and we will not allow to eat anything for 2 hours. Okay. After 2 hours, we will check the sugar level again. This is postprandial glucose sugar, postprandial sugar, or it is 2-hour plasma glucose, and this test is called as oral glucose tolerance test. If this 2-hour plasma glucose, if it is more than 200 milligram per dl, it is a case of diabetes. So we are having 4 diagnostic criteria. If anyone is present, it is a case of diabetes. So you can do any one test, all tests are good. Now, out of these 4 diagnostic criteria, our HbA1c, it is very important. Few important points regarding HbA1c. HbA1c, it is glycated or glycosylated hemoglobin. Some important points regarding HbA1c. Suppose this is blood and this glucose is present in blood, and in a diabetic patient, when glucose level increases in blood, this increasing glucose, it will combine with hemoglobin and it will form glycated or glycosylated hemoglobin, which is called as HbA1c. Now, what is the importance of HbA1c? It reflects the glycemic history. It reflects the glycemic history over the previous 2 to 3 months. Okay, so it will tell you about the glycemic control or glycemic index of our patient for last 3 months, that is HbA1c. Now there are some conditions which interfere with HbA1c report. These conditions are hemoglobinopathy, uremia, reticulocytosis, transfusion of blood, transfusion of blood, and anemia. Suppose, what is HbA1c? When increased glucose combines with hemoglobin, glycated hemoglobin, it is HbA1c. Okay, so normal hemoglobin is having some affinity with the glucose, and suppose if our patient is having hemoglobinopathy, hemoglobin is not normal. Suppose our patient is having thalassemia, then hemoglobin is abnormal. This is hemoglobinopathy. There is some defect in the globin chain of hemoglobin. Now we don't know what is the affinity of this abnormal hemoglobin towards glucose. So here we cannot trust HbA1c report. Okay. Similarly, similarly uremia. if it affects this reaction, it affects the reaction of glucose with hemoglobin, reticulocytosis, increased number of reticulocytes, transfusion of blood. When blood is transfused, normal blood with normal hemoglobin and normal glucose enters with the diabetic blood. Then we cannot trust HbA1c report. Anemia means decrease in hemoglobin. Decrease hemoglobin. Suppose if patient is a known case of diabetes and this patient is also having piles and because of piles patient is having bleeding. So what will happen? Hemoglobin will decrease and HB level, suppose hemoglobin level is 4. Okay, then again we cannot trust the report of HbA1c because lot of hemoglobin is lost outside the body. So in these conditions we cannot trust HbA1c report. So we do a second test. Name of the test is fructosamine assay. In this condition we use fructosamine assay, fructosamine assay or fructosamine assay. In fructosamine assay, we measure glycated albumin. We measure glycated albumin, and this fructosamine assay it will give the history of glycemic control for last 2 weeks. It will give history of glycemic control or glycemic status of our patient for last 2 weeks. Okay. Now all these points they are given in Harrison. Now one more extra point which is not in Harrison but it is very important to understand the concept of atherosclerosis in diabetes. Now what is happening when glucose is increasing in blood, it combining with hemoglobin, but actually this glucose it combines with multiple components of blood. So it will combine with multiple types of proteins. It will combine with albumin. It will also combine with globulin, collagen, fibrinogen. So this glucose, increasing glucose, it will combine with multiple components of the blood like albumin, globulin, collagen, fibrinogen, and it will form glycated products. It is called as glycated products. Now these glycated products they will be deposited on blood vessels. These glycated products they will be deposited on blood vessels, and these glycated products they will decrease the diameter of blood vessel. They will decrease the diameter of blood vessel. Okay, and once these glycated products they get deposited on blood vessel, they will act as the oxidative radicals and they will damage blood vessel. So when glycated products acting as oxidative radicals they are deposited on blood vessels, they will cause injury to blood vessel. So there will be inflammation in blood vessel, and after injury inflammation will start. After inflammation healing will occur, and after healing fibrosis will occur. Normal blood vessels are elastic in nature. The walls of the blood vessels they are elastic. They can dilate, they can constrict. Now because of the injury and because of the fibrosis, these walls, their elasticity, it will decrease, compliance will decrease, and these patients they will form and they will have atherosclerosis of blood vessels because of these glycated products. So now because of deposition of glycated products, these patients will have increased risk of thrombus formation. Okay, so these patients they will have increased risk of stroke, increased risk of heart attack. So whenever HbA1c increases, glycated products are increasing and the risk of cerebrovascular accident or stroke or heart attack it also increases. So practically it is very difficult to measure glycated products. So practically we measure only glycated hemoglobin. So if HbA1c is increasing, all glycated products are increasing, and risk of atherosclerosis, risk of thrombosis, thromboembolic episode, it also increases. Okay. This is the importance of HbA1c. Now we have diagnosed the patient of diabetes. After diagnosis, we want to treat the patient, and before treatment, we should know what is our goal of treatment, what we want to achieve. So, first we will write the treatment goals in diabetes. So now give the heading: treatment goals for diabetes. Index and our goal. Here we want to achieve HbA1c below 7%. Please remember these values. When HbA1c more than 6.5, it is a case of diabetes. Diagnostic criteria of diabetes. Okay. and and in treatment, we want to reduce HbA1c to less than 7%. If a patient is coming to you and in the first visit, we will check HbA1c report, and if HbA1c is 9, we will start the treatment, and target of our treatment is to decrease HbA1c to less than 7%. Then target of fasting blood sugar level, preprandial plasma glucose, it is 80 to 130 milligram per dl. We want to keep fasting blood sugar between 80 to 130. Then ppbs less than 180 milligram per dl. Blood pressure, we want to keep blood pressure of our patient below 140 by 90. LDL, low density lipoprotein level, we want to keep it below 100 milligram per dl. HDL, more than 40 milligram per dl in male, and more than 50 milligram per dl in females. Triglycerides, less than 150 milligram per dl. So this is our target of diabetes. Okay, now we want to start the treatment. So management of diabetes. In treatment of diabetes, our first step is always diet and exercise. Exercise increases insulin sensitivity. Okay, we will tell the patient to do regular exercise daily for 15 to 20 minutes. Then we will tell him what to eat, what not to eat. The complete diet chart we will give to our patient. And if still sugar is not controlled, then we have to add drug, which is metformin. Metformin is always the first drug which should be started, but before starting metformin, you should know what are the contraindications of metformin. Okay, we will discuss contraindications in few minutes. So first, diet exercise in drugs, we will start metformin. After starting metformin, we will reassess HbA1c. We will reassess HbA1c. If it is less than 7%, then our target is achieved. We have to continue our drug. But if still HbA1c is more than 7%, then we have to add second drug with different mechanism of action. Now the question is when to repeat HbA1c. Okay, when to repeat HbA1c. Now, generally, we first repeat FBS level and PPBS levels. The target of FBS, we want to decrease FBS below 130 and we want to decrease PPBS below 180. Okay, this is our target. We will start diet, exercise and metformin. After starting the treatment, after 10 days, 15 days, according to our experience, we will repeat fasting blood sugar and postprandial blood sugar. If FBS and PPBS it is under control, means FBS becomes less than 130, PPBS becomes less than 180, we will say that our patient is having good glycemic control. Our patient is having good glycemic control. And if our patient is having good glycemic control, then we repeat HbA1c 6 monthly. If our patient is having good glycemic control, then we will repeat HbA1c after 6 months. But if our patient is having poor glycemic control means FBS more than 130, PPBS more than 180, means sugar levels are not controlled even after diet, exercise and metformin. Then in such patients we will repeat HbA1c after 3 months. Okay. These are the guidelines to repeat HbA1c. There are no special guidelines for FBS and PPBS. Generally, we repeat FBS, PPBS according to the condition of our patient. Suppose your patient is planned for cataract surgery in 10 days. Then you will start the treatment of diabetes and after 7 days you will repeat FBS, PPBS. If it is not controlled, you will increase the dose. And if it is controlled, then you will continue the same treatment and you will give fitness for surgery of cataract. Okay, so there is no fixed days when to repeat FBS, PPBS. Generally we repeat in 10 to 15 days. If it is controlled, then you can repeat FBS to PPBS after 1 month. Now we will reassess HbA1c report. If it is controlled, it is very good, continue our treatment. But even after giving metformin, following diet and exercise guidelines, HbA1c is not controlled, still it is more than 7, then with metformin we have to add second drug with different mechanism of action. We will discuss drugs in few minutes. Now after addition of second drug, again we will reassess HbA1c 3 monthly or 6 monthly according to poor glycemic control or good glycemic control. And if HbA1c is still more than 7%, then we are having two options. The best option is to start insulin and to continue with metformin. So the best option is to start insulin, but most of the patients they will refuse. Why? Because for insulin we have to take injections and it is not comfortable for a patient to take insulin daily before food. Okay, so generally most of the patients they avoid to take insulin, so they will ask you to give them more drugs. So with metformin we will add two other drugs. So with metformin, we will start with two other drugs, but these drugs, they should have different mechanisms of action. Okay, maximum you can give four oral drugs with different mechanisms of action. And after giving four drugs with different mechanisms of action, if still sugar is not controlled, then we have no option. We have to go with injections of insulin. Okay. Now, the drugs. For drugs, you should know the mechanism of all the drugs, the mechanism of action of all the drugs, plus what are their contraindication. This is the table from Harrison. In this, first we will see the metformin. Metformin decreases the hepatic glucose production, okay, and contraindication for metformin is serum creatinine more than 1.5 in male and 1.4 in female. The congestive heart failure, radiographic contrast studies, hospitalized patients, and acidosis. These are the contraindications given in Harrison. Okay. According to new guidelines of diabetes, you can use metformin if serum creatinine level is increased, but only if GFR is more than 30. So remember, GFR less than 30. GFR less than 30, it is the contraindication for metformin according to the new guidelines. Next, alpha glucosidase inhibitors. Alpha glucosidase inhibitors, acarbose, migditol, hoglibose. These drugs, they decrease glucose absorption, and contraindication for these drugs is renal and liver disease. Then dipeptidyl peptidase 4 inhibitors, sitagliptin, vildagliptin, commonly used as sitagliptin and vildagliptin. These drugs, they prolong the endogenous GLP-1 action. Contraindication reduced in renal diseases. We have to decrease the dose, and they should not be given in patients with heart failure, and possible association with ACE inhibitor induce angioedema. So ACE inhibitors should not be given with DPP-4 inhibitors. Insulin secretagogues, sulfonylureas, glimepiride. These drugs, they increase insulin secretion. As we have already seen, sulfonylureas, they will block the potassium channels and they will increase the insulin secretion. Contraindication is renal disease, liver disease. And then repaglinide, metiglinide, these drugs, they also increase insulin secretion. Contraindication is renal disease and liver diseases. Sodium glucose cotransporter 2 inhibitors, canagliflozin, dapagliflozin, empagliflozin. These drugs, they block sodium glucose transporter 2 they inhibit SGLT2, and they will increase the excretion of glucose through kidney. SGLT2, they are present in proximal convoluted tubule, and normal function of SGLT2 is to reabsorb the glucose when glucose enters in proximal convoluted tubule. So these drugs, they are increasing the glucose concentration in tubules of the kidney, and these drugs, they are also increasing the glucose in urine. So these patients are having increased risk of urinary tract infection. So please avoid these drugs if patient is giving you the history of burning micturition, or even if patient is giving you the history of past UTI or past history of fever with burning micturition or urinary tract infection, don't give these drugs. Then thiazolidinediones, rosiglitazone, pioglitazone, these drugs, they will decrease insulin resistance and they will increase glucose utilization. but these drugs are contraindicated in heart failure and liver disease. Amylin agonists, pramlintide, these drugs they decrease or they cause slowing of gastric emptying and they decrease the glucagon. These drugs should not be given with any other drug which can decrease the motility of gastrointestinal tract. GLP-1 receptor agonist, exenatide, liraglutide, these drugs they increase insulin and decrease glucagon and also they cause slow gastric emptying. These drugs are contraindicated in renal diseases and agents. These drugs should not be given with other drugs which can decrease intestinal motility. Medullary carcinoma of thyroid, it is also contraindication for GLP-1 receptor agonist. Insulin. Insulin increases glucose utilization. It decreases hepatic glucose production. Okay, but this insulin it can cause hypoglycemia. So hypoglycemia it is contraindication for insulin. After this you should know different types of preparations of insulin. In this the most important you should know which insulins are short acting and which insulins are long acting. Okay, so short acting insulin for our exam it is aspart glulisine lispro regular. So remember GAL 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 glulisine aspart lispro. They are short acting insulin and their duration of action of first three it is 4 hours and action start in less than 0.25 hour. 0.25 hour means 15 minutes. Okay, and regular insulin it is most commonly used insulin in our wards. So please remember everything about regular insulin. Action of regular insulin start in 30 minutes and action of regular insulin it will last for 6 hours. So action of regular insulin it acts for 6 hours. It is your MCQ. Then Glargine, long-acting insulin, they are datimer and glargine. This datimer and glargine, they will act for 24 hours. Datimer and glargine, they will act for 24 hours. And NPH, this insulin, it will act for 16 hours. So these are the important insulin. Okay. So this is the diabetes. In exam they will give you patient is having chronic kidney disease, which of the following drugs should not be given. Patient is a case of diabetes and patient is diagnosed with cirrhosis of liver, which drug should not be given. Okay, so in exam they will ask you MCQ like this. So you should know the contraindications for all drugs and these drugs they will be covered in detail in pharmacology. Now I am interested in next topic, which is complications of diabetes. So give the heading complications of diabetes. These complications they are acute complications and chronic complications. Acute complications of diabetes and chronic complications of diabetes. In acute complications of diabetes, we have to learn first very important disease which is diabetic ketoacidosis DKA. And second HHS hyperglycemic hyperosmolar state. hyperglycemic hyperosmolar state. Chronic complications of diabetes. They are of two types. Microvascular complications and macrovascular complications. Microvascular complications, they are retinopathy, nephropathy, and neuropathy. Macrovascular complications, they are cerebrovascular accident or stroke, myocardial infarction or ischemic heart disease, and peripheral arterial disease. Okay, these are the complications of diabetes. The most important for our exam, it is diabetic ketoacidosis, very important topic for our exam. And second, diabetic neuropathy, it is also very important for our exam. So we will discuss these two topics in very detail. So first we will discuss diabetic ketoacidosis. So give the heading DKA. DKA, diabetic ketoacidosis. This diabetic ketoacidosis, it is common in type 1 diabetes. It is common in type 1 diabetes. Reason is type 1 diabetic patients, they are having severe deficiency to insulin. These patients are having severe deficiency of insulin. Antibodies are destroying the beta cells, so beta cell number of beta cells are decreased, so insulin secretion is severely decreased. Now we will understand the pathogenesis. What is the reason? Now suppose this is our cell and this is blood vessel. This is blood. Now some glucose is present in blood. Glucose in blood can enter in cell, and now cell will utilize the glucose for production of ATP, that is energy. But this transfer of glucose from blood to cell, it requires insulin. Insulin is important. Insulin is required for transfer of glucose from blood to cell. Now what is happening in type 1 diabetes? Insulin is absent. Insulin is not there. So glucose from blood is not able to enter in cell. So now what will happen? Glucose in cell will decrease, but glucose in blood will increase. So our patient will develop intravascular hyperglycemia. Our patient will develop intravascular hyperglycemia. At the same time, our patient will develop intracellular hypoglycemia. Our patient is having intracellular hypoglycemia. Now, these hypoglycemic cells, they will give feedback to our brain that we are not getting the glucose. We are hungry. We are not having glucose for production of ATP. In response to this feedback from hypoglycemic cells, our brain will start counter-regulatory mechanism. Now, what is counter-regulatory mechanisms? There will be increase in growth hormone. There will be increase in growth hormone, glucagon, cortisol, epinephrine. All these hormones will increase, and these hormones, they will increase gluconeogenesis and glycogenolysis. Gluconeogenesis and glycogenolysis. Gluconeogenesis means synthesis of glucose from non-carbohydrate substances. Non-carbohydrate substances means fatty acids, proteins, that is amino acids. They will be converted to glucose. And glycogenolysis means breakdown of stored form of glucose, that is glycogen. So these two processes will be stimulated. When gluconeogenesis and glycogenolysis it is stimulated, we will see what happens in different parts of the body. So first we will see what happens in muscles. Now, in muscles, suppose these are muscles. Muscles are having glycogen, and glycogenolysis is started. So this glycogen, it will be converted to glucose 6-phosphate. And then this glucose 6-phosphate, it will be converted to lactic acid. In muscles, glycogenolysis is started. So glycogen is converted to glucose 6-phosphate. Glucose 6-phosphate is converted to lactic acid. It is happening inside the muscle. Now this lactic acid from muscle, it will be transported to blood. So lactic acid, it will enter in blood. Now lactic acid from blood, it will go towards liver. So this lactic acid, it will enter in liver, and our liver is stimulated for gluconeogenesis. So this lactic acid, it will be converted to glucose. This lactic acid, it will be converted to glucose. This is gluconeogenesis, formation of glucose from lactic acid. It is happening inside the liver. Now liver will transfer this glucose into blood. Now liver will transfer this glucose into the blood. So what will happen? Glucose level in blood will increase. Patient is already having hyperglycemia. and because of glycogenolysis and gluconeogenesis, glucose level in blood is increasing, but this glucose in blood it is not able to enter in cell. This is the main problem. So patient is developing severe hyperglycemia, and because of severe increase in glucose in blood, patient will have increased serum osmolality. Increased serum osmolality. This increased serum osmolality, it will stimulate thirst center in brain, and patient will have polydipsia. Patient will have clinical feature polydipsia. Now, serum osmolality increases, it stimulates the thirst center, and this increased glucose it will go towards kidney. Kidney is getting large amount of glucose, and now kidney will try to excrete the glucose. And when kidney is trying to excrete the glucose, then frequency of urination will increase and patient will suffer from polyuria. And when kidney is trying to excrete glucose from blood, kidney will utilize the water. So lot of water is used for excretion of glucose. So lot of water is lost in urine. Patient will suffer from dehydration. Patient will suffer from dehydration. Then the cells are hypoglycemic, cells are still not getting the glucose. Glucose is increasing in blood but not able to enter in cell. So cells are continuously giving signals to our brain that we are hypoglycemic, we are not getting the glucose, we are hungry. So hunger will increase, and when hunger increases, patient will have clinical feature polyphagia. So all diabetic patients they are having all these features: polydipsia, polyuria, polyphagia, and dehydration. Okay, these clinical features are because of glucose. Now let us see what happens in adipose tissues or fat. Now suppose this is fat or adipose tissue. Triglycerides. Fats are stored in the form of triglycerides. Fats are stored in the form of triglycerides, and when these fats they are converted to fatty acids, when these fats, now we will see what happens in adipose tissues and in fats. Suppose this is fat or adipose tissues. In adipose tissues, triglycerides are stored. Okay, so triglycerides are stored as a fat. When these triglycerides, when they are converted to fatty acids, this process is called as lipolysis. Okay, and this lipolysis is inhibited by insulin. Please remember this important relation of insulin with lipolysis. Insulin inhibits lipolysis. Insulin promote fat storage, and insulin promote use of glucose as energy. Okay, so insulin inhibits lipolysis, and in type 1 diabetes, patient is having severe deficiency of insulin. So insulin is absent. When insulin is absent, there is no one to stop lipolysis. So in patients of type 1 diabetes, lipolysis increases. So triglycerides will be converted to fatty acids. So lot of fatty acids will be formed, and these fatty acids they will enter in blood. So fatty acids will increase in blood. From blood, these fatty acids they will enter in liver. This is liver, and fatty acids from blood, they are entering in liver. Our liver is stimulated for gluconeogenesis, so fatty acids will be converted to glucose, and this glucose, it will be transported to blood again. So patient is already having hyperglycemia, and our liver is making lot of glucose, and this glucose is entering in blood, and patient is developing severe hyperglycemia. But this glucose is not able to enter in cell because insulin is absent. Now, lot of fatty acids, they are entering in liver. Liver is trying to convert all fatty acids into glucose, but there is a limit. Liver has a limit. Liver is not able to convert all fatty acids into glucose. Now, lot of fatty acids are coming into the liver, and it is beyond the capacity of liver to convert all fatty acids into glucose. So some fatty acids, they are transported to mitochondria of liver. These fatty acids, they are transported to mitochondria of liver, and in mitochondria these fatty acids, they are converted to ketones, and this is the process of synthesis of ketones. And now these ketones in liver, they will be transported to blood. These ketones in liver, they will be transported to blood. Now, which ketones are synthesized? Ketones. First, acetone. This acetone is a gas. It will go towards the lungs and it will be expired. And this acetone, it will give sweet, fruity smell to breath. Then next ketone, it is beta hydroxybutyrate. Third, acetoacetate. These ketones are present in blood. What are ketones? Ketones are nothing but acids. Ketones are nothing but acids. Why are they called as acids? Because ketones donate H plus ions. So ketones, they are donating H plus ions. Lot of ketones are present in blood. Suppose this is blood, and lot of ketones are present in blood. These ketones, they are donating H plus ions. So now lot of H plus ions are present in blood. As H plus ion concentration increases in blood, pH of blood will decrease and blood will become acidic. So patient is having acidosis. This acidosis is because of ketones, so it is ketoacidosis. And patient is a case of diabetes, so it is a case of diabetic ketoacidosis. Now, lot of H plus ions are present in blood, and now our body wants to remove these H plus ions. Our body wants to neutralize these H plus ions, and to neutralize these H plus ions, we are having a buffer system. We are having a buffer in our blood, which is bicarb. So these H plus ions which are coming from ketones, they will be neutralized by bicarbs, which is naturally present in our blood. H plus will combine with SCO3 minus, it will form H2CO3. It will be converted to H2O and CO2. And this CO2, it will go towards brain and it will stimulate respiratory center. It will stimulate respiratory center, and when respiratory center is stimulated, respiratory rate will increase. Patient will have hyperventilation. Patient will have hyperventilation. And when patient is hyperventilating, then arterial carbon dioxide or amount or concentration of carbon dioxide in blood will decrease. This hyperventilation is also called as Kussmaul's breathing. This is your MCQ. Kussmaul's breathing, a characteristic feature of diabetic ketoacidosis. It is nothing but acidotic breathing. Okay. Now, these water molecules, they are present in blood, and these water molecules, they will be utilized by kidneys for excretion of glucose. The water molecules, they will go towards kidney. Kidney will excrete these water molecules for excretion of glucose, and patient will suffer from dehydration. Patient will suffer from dehydration. Then these ketones, they can directly stimulate chemotrigger zone. Ketones, they can directly stimulate chemotrigger zone. And when chemotrigger zone is stimulated, patient develops severe nausea, vomiting. Then ketones, they irritate gastric mucosa. So patient develops severe abdominal pain. So characteristic features of diabetic ketoacidosis because of ketones, they are nausea, vomiting, abdominal pain, nausea, vomiting, abdominal pain, and Kussmaul's breathing. And Kussmaul's breathing. This dehydration, it is because of ketones, but it is not only because of ketones. It is not specific for ketones. Patient is having dehydration also because of polyuria, which is also because of increase in sugar level. Okay, so characteristic features because of ketones is nausea, vomiting, abdominal pain, Kussmaul's breathing. Then lot of ketones, they are present in blood. Our body wants to remove the ketones. Our body wants to excrete or to replace or exchange H plus ions from blood. In that process, what happens? Suppose this is blood. In blood, lot of H plus ions are present because of ketones, and suppose this is cell. This is our normal cell, and this cell is having lot of potassium ions. Now our body wants to remove H plus ions from blood, and to remove H plus ions from blood, now our body will exchange these H plus ions with potassium ions of cell. So hydrogen from blood, it will enter in cell, and potassium from cell, it will enter in blood. So there will be exchange of H plus with K plus, and because of this potassium from cell, it is entering in blood. So patient will develop intravascular hyperkalemia. Patient will develop intravascular hyperkalemia and intracellular hypokalemia. And this hyperkalemia, it increases the risk of cardiac arrhythmia and cardiac arrest in a patient of diabetic ketoacidosis. Now here one point is very important. It is what is the relation of insulin with potassium? Relation of insulin with potassium is that insulin shifts potassium from blood to cell. A very important sentence. Please remember this. Very basic and very important. Insulin shifts potassium from blood to cell. Okay. So insulin is a treatment of hyperkalemia. Hyperkalemia because of any cause. You can give insulin because insulin will shift potassium from blood to cell. And what is the problem in diabetes, especially in type 1 diabetes? Patient is having severe deficiency of insulin. So this insulin is absent. When this insulin is absent, there is no one who can transfer this potassium from blood to cell. So potassium, it will increase in blood, patient will develop hyperkalemia, and it will increase the risk of cardiac arrhythmia in a patient of diabetic ketoacidosis. Now, next, what is meaning of anion gap? Formula of anion gap given in Harrison is concentration of sodium minus concentration of bicarb plus chloride. Some books they are mentioning concentration of sodium plus potassium minus bicarb plus chloride. But Harrison is not mentioning the potassium, so I am giving you sodium minus bicarb plus chloride. Now, in diabetic ketoacidosis, H plus ions are increasing in blood, but H plus ions they are not included in the formula of anion gap. So increase in H plus is not directly affecting the anion gap, but this increase in H plus, this H plus, it is combining with bicarb. So bicarb concentration in blood is decreasing. So because of increase in H plus, bicarb decreases, and because of decrease in bicarb, anion gap will increase. So first MCQ, in diabetic ketoacidosis, anion gap increases. Second, reason for increase in anion gap is decrease in bicarb. And reason for decrease in bicarb is H plus, and reason for H plus is ketones. Okay. Now, treatment. Treatment of diabetic ketoacidosis. Treatment of diabetic ketoacidosis consists of three important points. First important point is intravascular fluid, intravenous fluids or intravascular fluids. We will give a lot of IV fluids like normal saline because patient is severely dehydrated. Okay. Then next one, we will give insulin. And third one, we will monitor potassium level. Okay, so these 3 points are very important: intravascular fluid, insulin, and potassium. To understand the treatment of diabetic ketoacidosis, we will first understand the actual clinical scenario. Okay, so let us assume we are having a patient. Patient is 21-year-old male, and he is known case of type 1 diabetes. 21-year-old male, he is a known case of type 1 diabetes. Patient is having severe vomiting, loose motions, severe vomiting, loose motions, fever since 3 days. Patient is having severe vomiting, loose motions and fever since last 3 days. Okay, and today since morning patient is having severe abdominal pain. patient is having severe abdominal pain, nausea, vomiting is still there, then patient had started breathing difficulty since morning. The patient is having abdominal pain, nausea, vomiting, breathing difficulty. That is Kussmaul's breathing. These features are since 1 day. These features are since 1 day. So initially patient is having infection in the intestine. Any infection, any stress, any anxiety, even surgery, it will increase the demand of insulin. Patient is a known case of diabetes. Patient is already having deficiency of insulin. In that patient is getting secondary infection, and this secondary infection, it will increase the demand of insulin. So now patient will suffer from very severe deficiency of insulin, and patient will enter in diabetic ketoacidosis. Okay, so now patient is in diabetic ketoacidosis, and patient is coming to us with all these complaints and with history of acute gastroenteritis. Now on examination we got sugar levels. They are around 565. Sugar levels are around 565. Okay, urine ketones, blood ketones are present. Now how will you treat, how will you manage your patient? In such patient, our first step is always we have to start IV fluids. We will give intravenous fluids, and generally we give normal saline. Okay, so first step, we will start with IV fluids and we give normal saline. It is 0.9% normal saline. It is given at the rate of 15 to 20 ml per kg. Okay, so in treatment we give intravascular fluid, normal saline 0.9%, and we give 15 to 20 ml per kg per hour for first 3 hours. Now after first 3 hours we will decrease the rate of IV fluid and we will use 250 to 500 ml per hour. Still, sugar levels, it will become less than 200 milligram per dl. Okay, some books are saying 250, some are saying 200. It is not important, just we have to decrease the sugar to 250, less than 250. Okay, so now when patient is having severe hyperglycemia, we are giving lot of IV fluids, so we are diluting the sugar, we are adding water to sugar. Because of dilution, sugar level will decrease. Then patient is having severe dehydration, so we are giving IV fluids, it will correct dehydration. Okay, and when there is increase in sugar in blood, normally whenever sugar level in blood increases, it will cause decrease in sodium concentration. Okay, according to Harrison, sentence from Harrison, when sugar level in blood increases by 100 milligram per dl, by 100 milligram per dl, sodium concentration in blood decreases by 1.6 milliequivalent per liter. It is sentence from Harrison, but mechanism is not given in Harrison. Mechanism is very simple. Suppose this is blood and in blood sugar level is increasing, so glucose level is increasing, And suppose these are cells. This blood is also having sodium. Now, when glucose level increases in blood, serum osmolality increases. Now this increasing glucose in blood, it will attract water molecules from extravascular space. So water molecules which are outside the blood, water molecules which are outside the blood vessel, they will be attracted and they will enter in blood. Now lot of water molecules from extravascular space, that is intracellular and interstitial space, they will be shifted to blood, and these water molecules, they will dilute the sodium. So number of sodium ions, actually they will remain same, but they will be diluted. So concentration of sodium will decrease. And evidence-based medicine, when we calculate this change in sugar and sodium, whenever sugar increases by 100 milligram per dl, sodium level decreases by 1.6 milliequivalent per liter. Okay. So generally, these patients are having hyponatremia, so we prefer normal saline in these patients of diabetic ketoacidosis. Normal saline, it is having lot of water molecules and sodium ions. So also there is a risk of hypernatremia. When we are giving so much amount of normal saline, there is a risk of hypernatremia. So at the time of admission or at the time of presentation, we always check sodium level, and after 12 hours again we will repeat sodium level. Normal sodium level is 135 to 145 milliequivalent per liter, and if sodium level is increasing, if sodium level is going above normal because of IV fluids, then we have to change the fluid to 0.45% normal saline. 0.45% normal saline. So please remember, in the case of diabetic ketoacidosis, sugar level increases which causes decrease in sodium. So we prefer normal saline, but we will monitor sodium level, and if sodium level increases, then we will give 0.45% normal saline. 0.45% normal saline is having lot of water molecules. Sodium ions are very less in 0.45% NS. Actually, 0.45% NS, it is also called as half NS, and it is a treatment of hypernatremia. Okay. Now, second important point in a patient of diabetic ketoacidosis, it is insulin. In a patient of diabetic ketoacidosis, we give insulin, and generally we prefer insulin regular, or you can say we prefer short acting insulin. It is endocrine emergency. Diabetic ketoacidosis, it is endocrine emergency, so we give insulin intravenously, and the dose, loading dose we give is 0.1 unit per kg, followed by continuous infusion at the rate of zero point 0.1 unit per kg per hour. So now we are giving regular insulin intravenously, okay, and we are giving insulin continuously. For suppose, just for example, if weight of patient is if weight of patient is 50 kg, then we will give 5 units intravenous directly. Okay, it is a loading dose, followed by we will give 5 units per hour infusion. Okay, and we will continuously give this infusion still sugar level becomes less than 200. Still sugar levels becomes less than 200 milligram per dl. Okay. Now, what is the main role of insulin in a patient of diabetic ketoacidosis? The main action of insulin is to stop lipolysis. Is to stop lipolysis. What? Because lipolysis is responsible for the whole drama. Okay, lipolysis was responsible for formation of ketones and ketones was responsible for acidosis. So we will give insulin and the very small amount of insulin is required to stop lipolysis. Okay, other actions of insulin, it will decrease the glucose, it will shift potassium from blood to cell. Yes, it is correct. But the main action is to stop lipolysis. Now, potassium monitoring. Potassium. First, normal level of potassium is 3.5 to 5.1 or 5.2 milliequivalent per liter. This is the normal level of potassium in blood. First, very important sentence from Harrison. If serum potassium level, if it is less than 3.3 milliequivalent per liter, then it is contraindication for insulin. It is contraindication for insulin. Okay, so please remember, before giving insulin, you must check potassium level. Without checking potassium level, you cannot give insulin. Suppose if patient is having potassium level less than 3.3, which is below normal, and if we give insulin intravenously, then what will happen? The potassium in blood, it will enter in cell. Okay, patient was having low potassium, now it will severely decrease. Patient will suffer from hypokalemia, severe hypokalemia. Severe hypokalemia, it is a risk factor for cardiac arrhythmia. Patient will develop cardiac arrhythmia, cardiac arrest, and it can result in a death of patient, not because of disease, because of the treatment. So in all patients of diabetic ketoacidosis, or whenever you want to give insulin intravenously, you have to check potassium level. Okay. Now, the most common doubt here, diabetic ketoacidosis, this patient generally they have hyperkalemia. Then why are we checking the potassium? We should give insulin directly because these patients should have hyperkalemia. But now come back to our patient. Our patient who was having severe vomiting and diarrhea. Patient has developed acute gastroenteritis first. Because of vomiting and diarrhea, patient may have low level of potassium. So these patients may have hypokalemia, and after development of hypokalemia, these patients they may enter in diabetic ketoacidosis. So potassium level may be normal or below normal. So always there is possibility of hypokalemia in a patient of diabetic ketoacidosis. So it is a rule that before giving insulin we have to check potassium. But it is not always possible to check potassium. Sometimes our lab is not working or lab is not available, potassium reagent is not available. So we are not able to check the potassium level in serum. So in that cases or generally in practice, our first step we do ECG. In ECG we will see T waves. If patient is having tall T waves, if patient is having tall T waves, then patient is having hyperkalemia. And if our patient is having absent T waves, or presence of U waves, then our patient is having hypokalemia. Okay, so in practice we do ECG. In ECG we see T waves. If T waves are tall, patient is having hyperkalemia, you can give insulin. And if our patient is having absent T waves, low amplitude T waves, or presence of U waves on ECG, patient is having hypokalemia, don't give insulin. Give potassium chloride, correct potassium, then you can go for insulin. Okay. Now what is your MCQ? Potassium less than 3.3. Potassium less than 3.3. It is a contraindication for insulin. In such patient, first step we have to correct potassium. After correction of potassium, you can give insulin. Now, what are the treatment guidelines given in Harrison for potassium? Now suppose patient is a case of diabetic ketoacidosis. According to Harrison, in a patient of diabetic ketoacidosis or any patient, if you are giving insulin intravenously, you have to check potassium 4-hourly. Okay, in a patient of diabetic ketoacidosis during treatment, you have to check potassium 4-hourly. Okay, next important part, less than 3 potassium level less than 3.3, it is contraindication for insulin. Now again come back to our patient. Patient is having hypokalemia, so we cannot give insulin. First step, we have to correct potassium by giving potassium chloride. So here I will write level of potassium in serum. Then shall we give insulin or not? And here injection of potassium chloride. Okay, now we are discussing the guidelines or the treatment given in Harrison. Our potassium level in our patient is less than 3.3, so we cannot give insulin. Here we have to give injection of potassium chloride at the rate of 40 to 80 milliequivalent per hour. Okay, then if potassium level it increases, it goes above 3.3, then we can start insulin. Okay, because patient is having diabetic ketoacidosis. Okay, so we are giving injection potassium chloride. After 4 hours we will repeat potassium, and this time potassium level is suppose 3.4. So now we can start insulin with 0.1 unit per kg loading dose followed by 0.1 unit per kg per hour. But this patient is also having very high risk to develop hypokalemia, so we have to continue injection of potassium chloride with the same rate. Again after 4 hours, we will repeat potassium level. And this time potassium level is between 3.5 to 5.2 milliequivalent per liter. Now it is the normal level of potassium. So for diabetic ketoacidosis, we can continue insulin till sugar becomes less than 200 milligram per dl. And here we can decrease the dose of injection of potassium chloride to 10 milliequivalent per hour. So here we will decrease the dose. Again after 4 hours, we will repeat potassium, and if potassium level, if it becomes more than 5.2, then definitely we have to continue insulin, as insulin is a treatment of hyperkalemia. But here we have to stop injection of potassium chloride. Okay, so this is the treatment protocol. This is the treatment protocol for diabetic ketoacidosis. So important points in this: first step in the treatment of diabetic ketoacidosis is always IV fluids. Okay. Second important point, Before giving insulin, we must check potassium level. If it is not in the option, we have to select, we have to do ECG. What is contraindication for insulin? If potassium level is less than 3.3, it is contraindication for insulin. We must correct potassium level first, then we can give insulin. Okay. Now, after diabetic ketoacidosis, next topic is HHS. Full form is hyperglycemic hyperosmolar state. Hyperglycemic hyperosmolar state, it is more common in type 2 diabetes. It is more common in type 2 diabetes. Because these patients are having relative insulin deficiency and inadequate fluid intake. Now, these patients are not having severe deficiency of insulin. These patients are having mild to moderate deficiency of insulin. So some amount of insulin is always present in blood and very small amount of insulin is required to stop lipolysis. Okay, so small amount of insulin, it will stop lipolysis and ketone synthesis can be stopped. So generally in this patient ketone synthesis is absent, ketones are absent. Now whole pathogenesis of diabetic ketoacidosis and HHS, it is same, completely same. Only one very big difference is there, which is absence of ketones. Now we will write some important lines from Harrison. Insulin deficiency, it is not severe, it is mild to moderate. And this insulin deficiency, it will increase hepatic glucose production. But patient is having some amount of insulin always present in blood, so generally ketone synthesis is absent. Absence of ketosis. Mild acidosis can occur. It This mild acidosis, it is because of increased lactic acid. Clinical features. All clinical features because of increase in glucose in blood, they will be present. So which clinical features will be present? Polyuria, polyphagia, polydipsia, clinical features of dehydration, they will occur. So patient will have mainly polyuria, polydipsia, polyphagia, clinical features of dehydration. These are the main clinical features. Okay. Now, these patients are known case of type 2 diabetes. So, these patients, they think that polyuria, polydipsia, it is normal for me. I am a diabetic patient, so it is going to happen. So, these patients, they are not coming to us. And these patients, they are also not drinking water. Why? Because they are suffering from polyuria. So, they think whenever if I drink lot of water, polyuria will increase, so they will try to avoid water. So inadequate fluid intake, and because of polyuria, because of increased sugar, these patients, they are suffering from dehydration. So serum osmolality, it is increasing because of loss of water and increase in glucose. Now if it is not controlled, then this sugar or increased serum osmolality, it will attract water molecules from the cells or from the neurons. So water molecules from the neurons, they will be shifted to blood. So what will happen? There will be shrinkage of neurons. Now these neurons, they cannot work normally, and patient will develop confusion, seizure. So patient may enter in mental confusion, patient may develop seizure, and rarely patient also enters in coma. So there are two different scenarios. Commonly these patients, they will come to you for regular follow-up. They will come to you in OPD just for normal checkup, not having any severe symptoms, complaining of only polyuria and polydipsia. You will check the sugar level and you will get sugar level is 700, 800, but patient is not having any features of ketones. Patient is a case of diabetes, elder, having polyuria, polydipsia, sugar level more than 700. It is a case of HHS, hyperglycemic hyperosmolar state. But again, patient is not coming to you. Second scenario, patient may become serious because of increasing sugar level. Patient may have mental confusion, seizure. Patient may enter in a coma. Unconscious patient brought to the emergency. We have checked the sugar level. Sugar levels are more than 800, 900. Okay, so two clinical cases are possible. Now, what is important here? In hyperglycemic hyperosmolar state, your MCQ is, in MCQ exam they will ask you which of the following clinical feature is absent in HHS. Okay, so please remember absent clinical features. As we have seen that ketones are absent in HHS, so clinical features which are because of ketones, they will be absent in HHS. So clinical features which are because of ketones, they are nausea, vomiting, abdominal pain, Kussmaul's breathing. These clinical features, they are absent. Reason, ketones are absent. Okay, now treatment of HHS is similar to diabetic ketoacidosis, that is we will give lot of IV fluids, then we will monitor sodium level. If sodium level increases, then we will give 0.45% normal saline. Okay, then for sugar we have to give insulin in the same zero point 0.1 unit per kg followed by zero point 0.1 unit per kg per hour, and plus we have to monitor potassium level as we are giving insulin intravenously. So complete treatment protocol is same. Okay, now we have to differentiate diabetic ketoacidosis from HHS. So we will write differentiating points of diabetic ketoacidosis and HHS. Now we are writing a table from Harrison. First, glucose level in milligram per dl. In patients of diabetic ketoacidosis, serum glucose is between 250 to 600 mg per dl, while in HHS, sugar level is 600 to 1200 mg per dl. Okay, what is the reason? The patient of diabetic ketoacidosis, is coming to you for severe clinical features like abdominal pain, nausea, vomiting, Kussmaul's breathing. So patient will come to you in early stage because of severe symptoms. Patient comes to us in early stage before sugar crosses 600. And in patients of HHS, patient is a case of type 2 diabetes, elder patient not coming to the doctor because patient is not having any serious symptoms. Patient is having only polyuria, polydipsia. So patient is not coming to us in early stage. Patient will come to us in late stage after sugar crosses 600. Okay, so generally HHS, it is having high serum osmolality as compared to decay. In both patient, glucose level will increase. So in both patient, osmolality, serum osmolality, it will also increase. Normal serum osmolality, it is 275 to 295 milliosmol per liter. It will increase in both, but it is much more in HHS. It is more than 330 and less than 380, 330 to 380, while in diabetic ketoacidosis it is between 300 to 320. Now, next is serum sodium level. As I told you, when serum glucose increases by 100 mg per dl, sodium concentration decreases by 1.6 milliequivalent per liter. This is the sentence from Harrison. Now in Harrison, in the table, it is given that sodium concentration in decay, it is 125 to 135. In HHS, it is 135 to 145. Normal level of sodium, it is 135 to 145. Now here Harrison is contradictory to itself. Why? Initially Harrison said when glucose level increases, sodium level decreases. Okay, and here Harrison is saying that sugar level is more than 600 in HHS, still sodium level is normal. And here sugar level is less than 600, still sodium level is decreased. So here Harrison is contradictory to itself, but we are not here to find mistakes of Harrison, or there may be some mechanism which is not given in Harrison. So we don't know the exact mechanism or why Harrison is mentioning this. Okay, so we are here to just clear our exam, so we have to focus what is our MCQ. First MCQ, relation of glucose with sodium. Second MCQ, sodium level in HHS, it is generally normal 135 to 145, while sodium level in diabetic ketoacidosis decreases 125 to 135, but mechanism is not given in Harrison. Now, fourth point. Serum creatinine slightly increase, and here it is moderately increase. Okay, so serum creatinine will increase in both. Why? What is the reason of increase in serum creatinine? The reason for increase in serum creatinine is very simple. Creatinine is increasing because patient is having kidney injury. This kidney injury is because of dehydration leading to hypovolemia, and hypovolemia can cause kidney injury. Both patients are having kidney injury, both patients are having dehydration, but duration of dehydration is much more in HHS because patient is not coming to us in early stage. In decay, dehydration is present, but duration of dehydration is less as compared to HHS because patient is coming to us in early stage. So creatinine will increase in both, but slightly in DKA and moderately in HHS. Plasma ketones. It is +4 in DKA. Ketones are absent in HHS, but there are some theories which can say you may get ketones positive in HHS. Okay, so you can get ketones in HHS +1, and the exact mechanism of ketone formation in HHS it is not known. Okay, there is a theory which is proposed for this. It is called as muscle starvation theory. It is called as muscle starvation theory. In HHS, because of muscle starvation, ketones can be present. You can get +1 ketones in blood and urine, but amount of ketone is very small. The amount of ketone is so small that it cannot give clinical features. Okay, so a patient of type 2 diabetes will come to you with polyuria, polydipsia. You will check sugar level, it will be more than 700, but clinical features of ketones will be absent. You will check urine for ketone, blood for ketone, your blood test and urine test, it may show +1 ketones, but it doesn't mean it is a case of diabetic ketoacidosis. It is still a case of HHS because patient is a case of type 2 diabetes having sugar levels more than 600. Okay, patient is not having clinical features of ketones, only presence of +1 ketones in blood and urine. It is not sufficient to say it is a case of diabetic ketoacidosis. To prove a case of diabetic ketoacidosis, we have to check arterial blood gas level. We will check the pH of our blood. If pH of blood is decreased, then we will say it is acidosis. Okay. So in a blood test or in urine test, you may get +1 ketones. It doesn't mean it is a case of diabetic ketoacidosis. In HHS, you may get +1 ketones. Okay. Then 6. Serum potassium level. Because of ketones, potassium level increases in blood. So potassium may be normal or increase. It can be normal to increase, and here in HHS potassium level will be normal. 7. Arterial pH. Normal level of pH say 1.35 to say 1.45. This is normal level. pH will decrease and it will become 6.3 to 7.3. In HHS, it will be more than 7.3. pH is decreasing in decay because of ketones donating lot of H plus ions. Then serum bicarb level. Serum bicarbonate in decay, bicarb combines with H plus ions from ketones and bicarb decreases. Normal level of bicarb is 22 to 26 milliequivalent per liter. In DKA, this bicarb decreases and it becomes less than 15 milliequivalent per liter. In HHS, bicarbs will be normal. Then arterial carbon dioxide normal level is 35 to 45. In diabetic ketoacidosis, carbon dioxide decreases, it becomes 20 to 30, and in HHS it remains normal. Next, anion gap, it decreases because of decrease in bicarb. Decrease in bicarb is because of H plus. H plus are coming from ketones. So anion gap increases Here a 9 gap is normal in a patient of HHS. Next MCQ. Which of the following cannot differentiate decay from HHS? Please remember this point. Magnesium, chloride, phosphate. They cannot differentiate decay from HHS. They will be normal in both patients. Okay. So this table is very important. It is from the Harrison. Now, this is the completion of acute complications of diabetes. Now we will see chronic complications of diabetes. These chronic complications of diabetes, already I told you, it can be microvascular, it can be macrovascular. Now, microvascular complications, they are retinopathy, nephropathy, and neuropathy. Then macrovascular complications, they can be cerebrovascular accident or stroke, CVA, myocardial infarction or ischemic heart disease, and third, peripheral arterial disease. Peripheral arterial disease. Okay. Now we will understand the mechanism of microvascular and macrovascular complications. Okay. So now to understand this, draw a very simple figure. Suppose this is aorta. Okay. And this aorta is giving lot of blood. Aorta is giving lot of branches. These branches, they are traveling from proximal to distal. And as blood vessels, they are traveling from proximal to distal. Diameter of blood vessel is decreasing. You can see the diameter is decreasing. Okay. So now, next point, in diabetes, glucose level is increasing. Glucose combines with hemoglobin, plus glucose also combine with multiple components of blood, and in diabetes there are lot of glycated products, and these glycated products, they get deposited on blood vessels. So these are glycated products, and these glycated products, they get deposited on blood vessels. Okay. Now these glycated products, they will be deposited on large blood vessels, on medium blood vessels, and in small blood vessels. So obviously small blood vessels will be blocked. When small blood vessels are blocked, patient will develop some complications. They are called as microvascular complications. When large arteries are blocked, they will have some complications. They are called as macrovascular complications. Okay. So now small arteries, that is the arteries which are supplying our end organ. End organ means retina in eye. This retina, it is having blood supply. Now suppose this is the blood vessel which is supplying the retinal artery, and some amount of glycated product it get deposited in this artery. So diameter of artery is decreased, so less amount of blood is going towards retina. Patient will develop ischemia of retina. And if these glycated products, if they block the retinal artery or small arteries which are supplying the retina, then there will be infarct. It is called as diabetic retinopathy. It is called as diabetic retinopathy. This one. Okay. Then nephropathy. If you see our nephron, if you see our glomerulus, this glomerulus is having lot of blood vessels, and these blood vessels, they are not straight, they are having lot of turns inside. Their diameter is very small, plus they are having lot of turns. Because of this, what happens when glycated product enters in these blood vessels? First thing, these glycated products, they are not flexible. They cannot take the turn. Plus, diameter of blood vessel is very small. So these glycated products, they will be deposited in very tortuous veins of glomerulus. They will block the blood supply. They will cause ischemia to kidney. They will cause inflammation, sclerosis, and infarct in the kidney. It is called as diabetic kidney disease or diabetic nephropathy. Okay. Then most important for us is diabetic neuropathy. Diabetic neuropathy. Now we will understand diabetic neuropathy. So write down types of diabetic neuropathy. When I am saying neuropathy, neuropathy means diseases of nerves. Neuropathy means diseases of nerves. There are different types of neuropathies of diabetes. First one is DSPN, second one autonomic neuropathy, third one mononeuropathy consists of peripheral neuropathy and cranial nerves, and also plexopathy. So there are four types of diabetic neuropathies. The first one is DSPN. Full form, it is distal symmetric sensory motor polyneuropathy. Okay, it is called as DSPN. Now what happens in this neuropathy? To understand this, draw this figure. Now suppose he is a human. Okay, now suppose this is our spinal cord. This is spinal cord. Now all of you know we are having different types of nerves. We are having sensory nerves, motor nerves, and autonomic nerves. All nerves will be affected in diabetes because of decreased blood supply to nerves. Okay, but to understand DSPN, we will consider only sensory nerves. To understand DSPN, First we will consider only the sensory nerves. So this is spinal cord. We are having sensory nerves. Sensory nerves, they are carrying sensation from all parts of our body, and these sensory nerves, they are entering in spinal cord. Green color, all these are the sensory nerves, and these sensory nerves, they are carrying the information of pain, touch, temperature, joint position, vibration, and they are entering in the spinal cord. Now I will compare the diameter of blood vessel. If I see the diameter of blood vessel which is supplying proximal part of the sensory nerve, then I will compare this diameter with distal part of the same sensory nerve. So if you compare diameter of blood vessel supplying proximal part of nerve with diameter of blood vessel supplying distal part of nerve, you can easily understand that diameter of blood vessel which is supplying distal part of the nerve, it is having very small diameter as compared to the proximal part of the nerve blood vessel. Okay, all of you are getting this? The same concept. Blood vessels traveling from proximal to distal. Proximal blood vessel is having a large diameter, and the distal end of the blood vessel, it is having very small diameter. So the same concept, glycated products will be deposited on the blood vessels. Initially, distalmost part or the distalmost branch, it will be blocked because it is having smallest diameter. So the blood vessel which is supplying the sole of our foot, it will have decreased blood supply. So what happens? Patient of diabetes, sugar is not controlled, so glycated products, they will increase, and these glycated products, they will accumulate in the blood vessel, the blood vessel of distalmost part, that is sole of foot. Okay, now these patients are having decreased blood supply to sensory nerves where on the foot. So patient will come to you with chief complaints of tingling, burning, pins and needle sensation. So patient is coming to us with tingling, burning, pins and needle sensations where bilaterally here at the sole. Patient is having bilateral sensation, tingling, burning, pins and needles bilaterally on the sole. Now, patient in the case of diabetes having tingling, burning, pins and needle sensation at the sole. So you will diagnose your patient as a case of diabetic neuropathy. Okay. Now, if at this time if sugar is well controlled, then you can reverse this neuropathy. But if the sugar is not controlled, patient is not taking care of his diabetes, then these symptoms will increase and they will go up from distal to proximal. They will involve the ankle, they will involve the knee joint. And when these glycated products, if they block the blood vessel completely, then now ischemia will be converted to infarct, and now patient will come to you with the complaint of loss of sensation. Patient will tell you that now I am not having any tingling, burning, okay, and now I am having severe loss of sensations. In the language of patient, patient will tell you, when I am walking on the ground, I am not getting sensations of the ground. I am not getting sensations of my slippers. There is slippage of slippers. Okay, I am not getting the sensation of slippers. I am having multiple injuries on my foot, but I am not having pain. Okay, when I am taking bath, I can feel hotness of water on upper part of my body, but I am not getting sensation of water, hotness of water at the sole. It means your patient is having loss of sensations. So patient will get multiple injuries, ulcers on foot, but patient is not having pain. It means your patient is having infarct of the sensory nerve. If sugar is not controlled, then this neuropathy will progress and it will block all blood vessels from distal to proximal, that is from small diameter to large diameter, and now both limbs will be affected symmetrically. So patient is having loss of sensations. It will start from the sole, it will reach towards ankle. After ankle, it will reach knees bilaterally and symmetrically. After reaching knees, it will reach mid-thigh level. Now these tingling, burning, pains and needle sensation, they will reach the mid-thigh, or patient is having loss of sensations up to the mid-thigh level. And if I cut the sensory nerve, at this point I can see the diameter of blood vessel which is supplying the mid-thigh level is similar to the diameter of blood vessel which is supplying sensory nerve of hands. So when patient is having clinical features up to the mid-thigh level, then clinical features will start on the hands. Okay, so now patient will have tingling, burning, pins and needle sensations on hands. Okay, so clinically if you see the position of our hand, just stand and see the position of our hands. Our hands they are touching the mid-thigh level. So when neuropathy reaches mid-thigh level, clinical features begins in hand. Okay, and this type of neuropathy is called as gloves and stocking neuropathy. This type of neuropathy is called as gloves and stockings neuropathy, MCQ. Okay, now see this. Distal part is affected first. So distal, symmetric, both side, right, left, they are affected equally and symmetrically at the same time. So it is symmetric. Sensory nerves, motor nerves, both are affected. So it is sensory motor. Sensory features we have discussed. Motor features means muscles will be affected. So patient will have weakness, difficulty in walking. First muscles of soles will be affected, then muscles of ankles will be affected. So patient will have paralysis type features. Then polyneuropathy, multiple nerves will be affected. So it is distal, symmetric, sensory motor polyneuropathy. It is most common type of diabetic neuropathy. It is most common type of diabetic neuropathy. Second, after DSPN, second is autonomic neuropathy. Autonomic neuropathy means autonomic nerves will be affected. Autonomic nerves will be affected. There will be decreased blood supply to autonomic nerves. So patient may have autonomic symptoms like postural hypotension, bradycardia, tachycardia, sexual dysfunction, that is erectile dysfunction. So autonomic symptoms may occur. Then third one, patient may have plexopathy. In plexopathy, what happens? There is decreased blood supply to plexus. So it is also called as Bruns-Garland syndrome. It is also called as diabetic amyotrophy. Diabetic amyotrophy or diabetic radiculoplexopathy. Radiculoplexopathy. Okay. So now there is infarct or ischemia of plexus. Lumbar plexus, brachial plexus, both can be affected. Lumbar plexus or brachial plexus. Commonly affected is lumbar plexus. Patient will have severe back pain. Okay, it is a lower motor neuron lesion, so atrophy of muscle can occur. So it is also called as amyotrophic diabetic amyotrophy. Fourth one, mononeuropathy. Diabetes can affect a single nerve, so it is called as mononeuropathy. Now this mononeuropathy can consist of peripheral nerve. In peripheral nerve, it can be median nerve or ulnar nerve, and it can be cranial nerve. The most common cranial nerve affected in diabetes, it is third, that is oculomotor. And characteristic of involvement of oculomotor nerve in diabetes is pupil sparing neuropathy. Patient develops pupil sparing neuropathy, MCQ. Now, why it is called as pupil sparing neuropathy? Reason is very simple. The fibers which are supplying pupil, they are not affected in early stage. Now reason why these fibers are not affected. Again we have to see our basics from first year anatomy. All of you know that third nerve originates from midbrain. So suppose this is midbrain. Our midbrain is having motor nucleus of third nerve. Midbrain is having motor nucleus of third nerve, and this motor nucleus of third nerve, it is giving fibers. These fibers are motor fibers, and these fibers are controlling the movement of eyeball. Okay, so midbrain is having motor nucleus of third nerve. From motor nucleus of third nerve, motor fibers are originating. Motor fibers are supplying muscles of the eyeball. Okay. Now, our midbrain is also having Edinger-Westphal nucleus. Edinger-Westphal nucleus. These Edinger-Westphal nuclei present in the midbrain, they will give parasympathetic fibers, and these parasympathetic fibers, they are also traveling in the third nerve. So what is the third nerve? What is the third nerve? If I draw third nerve is this green color. This is our third nerve. What is meaning of nerve? Nerve, it is nothing but a hollow pipe. Nerve is a hollow pipe. In that hollow pipe, you can keep multiple fibers. You can keep sensory fiber, motor fibers, autonomic fibers. Okay. So this green color, it is our third nerve, and this third nerve, it consists of motor fibers coming from the motor nucleus of the third nerve and parasympathetic fibers from the Edinger-Westphal nucleus. Function of motor fiber is to supply the muscles of eyeball, and function of parasympathetic fiber is to supply the sphincter pupillae for constriction of pupils. Okay, now I will take section of the third nerve. I will take section of third nerve, and I will see what is happening in the third nerve. So I will draw a section of third nerve. So suppose this is section of third nerve. This is third nerve. If I see section of the third nerve, then in the center, the arrangement of fiber is like this. Motor fibers are present in the center of the nerve, and parasympathetic fibers are present surrounding the motor fibers. Parasympathetic fibers are present surrounding the motor fibers. So these are the parasympathetic fibers. Now, I will check the blood supply of the third nerve. So blood vessels, they are traveling from periphery to center, and as these blood vessels, they are entering into the third nerve, the diameter of blood vessels, it is decreasing. So as we go in, the diameter of blood vessel, it is decreasing. So simply I want to tell you, the diameter of blood vessel which is supplying the motor fiber, it is very small as compared to the diameter of blood vessel which is supplying the parasympathetic fibers. So our basic concept, in a patient of diabetes, glycated products, they will be deposited first in blood vessels which are having very small diameter. So in a patient of diabetes, glycated products, they will be deposited first in motor fibers, the blood vessels which are supplying the motor fiber. So patient will have weakness, difficulty in movement of the eyeball first. But if you check the pupil reaction, then pupils will be constricting to light. So pupil reaction will be normal, but motor fibers, they will show weakness. It is called as pupil sparing neuropathy. It is characteristic of diabetes. If sugar is not controlled, then glycated products, they will increase, and now they will block the blood vessel which is supplying the parasympathetic fibers. Okay, so these are the complications of diabetes. Now, after completing this, the next topic is two very small concepts. One is Somogyi effect and Dawn phenomenon. We will understand what is Somogyi effect and Dawn phenomenon. Now, suppose I have a patient of diabetes and the sugar of that patient is not controlled. Patient comes to me, patient is newly diagnosed as a case of diabetes, and that patient's fasting blood sugar, it is around 350 to 380. It comes 360, 370 like this. So according to the management protocol, first I have advised him to start strict diet, exercise, and also with that I have started with metformin. After diet, exercise, metformin, sugar levels are decreased to around 340. Okay, patient is not satisfied, patient again comes to me. So I have advised him to start the second drug, to add second drug. So we have added the second drug, glimepiride, and sugar levels after adding glimepiride, it is decreased to around 320. So still sugar is not controlled. So I have advised him to start insulin, but patient refused. Patient said, I'm not comfortable, or it is not possible for me to take insulin during daytime, so I can't take insulin, so give me the drug. So I have added the third drug, vildagliptin. After adding vildagliptin, sugar level is decreased to 310. Still it is not controlled. Okay, so I have decided to add the fourth drug, Oglibose. So now patient is taking metformin, glimepiride, vildagliptin, Oglibose, and sugar level is still around 300 to 330. So after taking so many drugs, sugar level is around 300 to 330, and we have reached 4 drugs with different mechanisms of action, and sugar is not controlled. So ultimately I have told the patient that now we have no option, we have to start insulin. So now patient says, okay, but I can take insulin only at the night. I can't take insulin during daytime. So we have decided to start insulin only at the night time and to continue the drugs at the daytime. So we have advised him to take insulin. So we have given insulin. According to the guidelines, we have given zero point 0.1 unit per kg. Weight of our patient was 80 kg. So we have given 8 unit of insulin at night. Okay. So now before dinner, just for example, suppose before dinner sugar level of patient was around 330. Okay, and patient has taken 8 unit of insulin. After taking 8 unit of insulin, patient takes the dinner, then patient sleeps very well. Okay, throughout the night, no symptoms, no complaints. Next day morning, patient wakes up and patient checks his fasting blood sugar level, and this fasting sugar blood level, it came to be 496. So now before insulin it was 330, after insulin it is 496. So now why this is happening, okay, now we will understand the mechanism, what happens after giving insulin. When we are giving insulin or when we are treating a patient of diabetes, what is our target? We want to decrease fasting blood sugar level below 180. So our target is we want to decrease FBS below 130. This is our target of FBS. Okay, and we don't want to go below 80, because if we go below 80, patient will develop hypoglycemia. So we don't want hypoglycemia. So we want our fasting blood sugar level, it should remain between 80 to 130. Now, when such patients are coming to us that after giving insulin sugar becomes 496 or it is increasing after giving insulin, then what we do, we will admit the patient just for 12 hours. Okay, or we will advise the patient to check sugar level throughout the night 2 hourly. So now we will keep the patient under observation and we will check the sugar 1 hourly or 2 hourly after giving insulin. So for example, patient is having sugar level of 330 at 8 p.m. Okay, and we have given 8 unit of insulin at 8 p.m. After 1 hour, that is at 9 p.m., sugar level decreases to 310. Again, we will check the sugar at 10 p.m. At 10 p.m., sugar level decreases to 280. So sugar level is decreasing, patient is responding. At 11 a.m., sugar goes down to 230. At around 12, sugar becomes 180 in the midnight. Okay, now patient sleeps at 11 or 12. Patient will go for sleep. Patient is sleeping now, but we are checking the sugar levels. Okay, 1 hourly or 2 hourly. At around 1 a.m., sugar touches 130. At around 1 a.m., sugar touches 130. So we are very happy that our target is reached at 1 a.m. But after 1 a.m., sugar will decrease and it will become 100 at around 2 a.m. Again sugar will decrease and it is going to touch 80 at around 3 a.m. So at 3 a.m. when patient is in the deep sleep, sugar is around 80, that hypoglycemia is going to develop. Before patient develops symptoms, that is, before patient develops symptoms, our body will start counter-regulatory mechanisms. And when counter-regulatory mechanisms start, cortisol, glucagon, growth hormone, epinephrine, all these hormones, they will increase and they will start gluconeogenesis and glycogenolysis. Because of gluconeogenesis and glycogenolysis, the sugar which was touching to 80, it will increase suddenly. And it will reach 496. It will reach suddenly, it will go above 400. So in this patient, you will get morning hyperglycemia because of counter-regulatory mechanisms to avoid hypoglycemia. Okay, this phenomenon is called as Somogyi effect. In Somogyi effect, patient develops hypoglycemia followed by hyperglycemia. Okay, it is called as Somogyi effect. Now, what is the reason for this Somogyi effect? The dose of insulin is 0.1 unit per kg according to Harrison. We have given the dose according to our book, but we can calculate dose of insulin, but we cannot calculate sensitivity to insulin. We don't know what is the sensitivity of our patient to insulin. What is the resistance of our patient to insulin? We cannot measure exact sensitivity. We cannot measure exact resistance to insulin. Okay, there are some formulas, but still they cannot give you the exact resistance or sensitivity to insulin. So what happens? 0.1 unit per kg. It is This value is given on the basis of evidence. That is, we have taken 100 patients of diabetes. Okay, suppose we have taken thousands patients of diabetes. Out of that 1000, to first 100 we have given 0.05 unit per kg dose of insulin. Next 100 patient we have given 0.07 unit per kg dose of insulin. Then next 100 patient we have given zero point 0.1 unit per kg dose of insulin. So we have given different dose of insulin to some group of patients of diabetes, and in all these groups we have seen that best response given by the group is 0.1 unit per kg. So most of the patients, they are giving very good response to 0.1 unit per kg dose. So we have decided to give zero point 0.1 unit per kg insulin to all the patients. Okay, or you can say 0.1 unit per kg. This dose is not causing hypoglycemia in most of the patients, so we give zero point 0.1 unit per kg dose to our patients. But in some patients, sensitivity to insulin is very high, so they will give very good response to insulin. 0.1 unit per kg dose, it will be a very high dose for that patient, because that patient is having high sensitivity to insulin or very low resistance to insulin. So as soon as we give insulin in a normal or appropriate dose according to guideline, but it is high dose for that patient because of high sensitivity to insulin. So the patient who was not responding to drugs, that patient will give you a very good response to insulin. So that patient will develop hypoglycemia, okay, followed by hyperglycemia because of counter regulatory mechanism. Now opposite can also happen. Opposite means some patient may have very high resistance to insulin. So when some patients are having very high resistance to insulin, these patients will not give very good response to insulin. So they will not have decreased level of glucose. So the patient, if patient is having very low sensitivity to insulin, or you can say very high resistance to insulin, then patients will not give very good response, and the sugar level, which is 330, this sugar, after giving insulin for some time it will decrease, and then throughout the night it will go on increasing. So this second phenomenon is also possible, which is called as dawn phenomenon. In dawn phenomenon, patient has very low sensitivity or very high resistance to insulin, because of which patient has hyperglycemia throughout the night. When patient is having hyperglycemia throughout the night, sugar is not coming down below 130 or below, or patient or sugar is not coming to normal level during night. Patient is having hyperglycemia throughout the night because of low sensitivity to insulin or because of very high resistance to insulin. Then you will say patient is having hyperglycemia because of insufficient insulin. It is called as dawn phenomenon. It is called as dawn phenomenon. In dawn phenomenon, the amount of insulin given to patient, it is not sufficient. So treatment of dawn phenomenon is to increase the dose of insulin. And in Somogyi effect, patient is responding and patient is developing hypoglycemia at the night. So the dose given to the patient, dose of insulin, it is very high dose for that patient. So treatment of Somogyi effect is decrease the dose of insulin. Okay, this is Somogyi effect and dawn phenomenon. Hypoglycemia. In hypoglycemia, first we will see causes of hypoglycemia. Most common cause is treatment of diabetes. Most common cause is treatment of diabetes. Then other causes: alcohol. Alcohol stimulate insulin secretion. Alcohol stimulates insulin secretion. Then hepatic failure. Diseases of liver like hepatitis, cirrhosis, they are responsible for hypoglycemia because the main two cycles, gluconeogenesis and glycogenolysis, they are mainly taking place in the liver. If liver is failed, then there will be impaired gluconeogenesis and glycogenolysis, which will cause decreased glucose level in blood. Then renal failure. Insulin is excreted by kidneys. If kidneys are failed, then insulin will remain in blood for long time and it will cause hypoglycemia. Sepsis. Sepsis increases peripheral utilization of glucose, so it causes hypoglycemia. Then hormone deficiency. In hormone deficiency, all hormones which are responsible for counter-regulatory mechanisms, for example, cortisol, growth hormone, glucagon, and epinephrine. Hormone deficiency of these hormones, it causes hypoglycemia. Then non-islet cell tumor. Non-islet cell tumor, for example, mesenchymal tumor. Then tumor of beta cells, or called as insulinoma. This tumor secrete insulin. So abnormal excessive secretion of insulin, it causes hypoglycemia. So these are some causes of hypoglycemia. Clinical features of hypoglycemia. Patient will develop palpitations, tremors, anxiety, sweating, hunger, pallor, increase heart rate, and increase BP. These are the clinical features of hypoglycemia. Now, when patient is having all these clinical features, then our first step, we will check the sugar level. There is an instrument called as the glucometer, and you can check the sugar. Within 5 seconds you will know what is the sugar level in blood. And if sugar level is below 80, then you will say patient is a case of hypoglycemia. Now, patient is having hypoglycemia and clinical features of hypoglycemia. If patient is conscious, oriented, and patient is able to swallow, then you will give oral glucose. Okay. And if patient is not conscious, patient is not able to swallow, then you will give intravenous glucose. After giving glucose, then patient will become normal or asymptomatic. That is reversal of symptoms after correction of glucose. All these 3 points, it is called as Whipple's triad. We will write what is meaning of Whipple's triad. Whipple's triad. First, patient should have symptoms of hypoglycemia. Patient should have symptoms of hypoglycemia. Second point, at the time of symptoms, we should check sugar level, and sugar level should be below 80. And if sugar is below 80, then you will say that patient is having hypoglycemia, and because of this hypoglycemia, patient is having clinical features. It is called as documented hypoglycemia. During symptoms, if you check sugar level and if it is low, then you will say patient is having documented hypoglycemia. Third point. Now you will give glucose orally or intravenously, intravenous dextrose, and after giving glucose, if patient becomes normal, it is Whipple's triad. That is reversal of symptoms. Reversal of symptoms after correction of glucose. After correction of glucose. Okay. Now, now what will they ask you in your exam? First, on the basis of investigations, they will ask you MCQs. That patient is coming to you with all these clinical features: sweating, hunger, pallor, increased heart rate, BP, palpitations, tremors, anxiety, and sugar level was 40/30. Okay, and they will give you that this patient with clinical features of hypoglycemia, he is having serum insulin and serum C-peptide reports. In this patient, if serum insulin is increased and C-peptide is decreased, or C-peptides are normal. In this patient, if insulin is increased but C-peptides are decreased, then this insulin is not secreted or not synthesized in our body. It is not endogenous insulin. because whenever insulin is secreted by beta cell, it is always secreted with C-peptide. Now only insulin is increasing while C-peptides are decreasing. So this is exogenous insulin. This is exogenous insulin. It means patient has taken injections of insulin or patient has taken high dose of insulin. Okay. Next, suppose if our patient is having increased insulin with increased C-peptide. Now patient is having increased insulin with increased C-peptide. It means our patient is having endogenous secretion of insulin. So there are two possibilities of increased endogenous insulin. First possibility, which is more common, is drug. Patient has taken any drug which can block potassium channel and it is increasing the secretion and synthesis of insulin by beta cell. The drug commonly responsible for hypoglycemia, they are sulfonylureas. Now for this in MCQ, you have to read a history of drug intake or treatment of diabetes. Patient is a known case of diabetes having hypoglycemia. Patient is taking regular drug. Then you will suspect patient is having drug induced hypoglycemia. Okay. And if patient is not giving proper history, patient is not conscious and patient is not able to give you the history of drug, then you will check drug level in serum and in urine. You can check drug levels in serum and urine. Then if patient is not having history of diabetes, not having history of any drug, and patient is developing recurrent hypoglycemia, reports are showing insulin is increased with C-peptide, then you will suspect a tumor like insulinoma. And for this insulinoma, to rule out insulinoma, you will do CT scan abdomen or you can also do PET scan. Then you will find out the tumor and treatment of choice is surgery, surgical resection of tumor. And if surgery is not possible, then we have to give the drug diazoxide. Okay, so this is hypoglycemia. Now we will solve MCQs of diabetes and hypoglycemia. Very simple MCQs. Which of the following findings can establish a diagnosis of diabetes mellitus? Fasting blood glucose 100. No. Fasting blood glucose, it should be more than 126. Then fasting blood glucose 125. No, it should be 126. Symptoms of diabetes plus random blood glucose of 190. No, it should be 200. It should be more than 200. Then glycosylated hemoglobin HbA1c more than 6.5%. It will diagnose a patient of diabetes. Laboratory values in a patient with diabetic ketoacidosis includes decrease anion gap. No, it should be increase. Patient should have increased anion gap. Increase magnesium levels. No, magnesium levels, they are normal. Normal to increase potassium level, yes, it is possible. Potassium level increases because of exchange of potassium with H plus ions. Decrease phosphate level, no, phosphate level remains normal. Magnesium, phosphate, they will remain normal. Okay, answer is C. All are seen in diabetic ketoacidosis except so small breathing is seen, dehydration it is also seen, Abdominal pain, it is also seen. Bradycardia, it is not a feature of diabetic ketoacidosis. Which of the following statement about dawn phenomenon is true? They have asked about true statement. Morning hyperglycemia with midnight hypoglycemia. No, it is false. Patient does not have hypoglycemia in the night. Patient has hyperglycemia throughout the night. Morning hypoglycemia. No, patient will have morning hyperglycemia. Morning hyperglycemia due to insufficient insulin. Yes, it is correct. Morning hypoglycemia is wrong. A correct answer is C. This patient will have morning hyperglycemia due to insufficient dose of insulin. Okay, or patient may have very high resistance to insulin. So patient is not responding to the given dose of insulin. Then, which of the following is characteristic of diabetes mellitus? Encephalopathy, myelopathy, neuropathy, myopathy. Diabetic neuropathy, it is the characteristic of diabetes. Okay, in neuropathy, that is diseases of nerves, DSPN, distal symmetric sensory motor polyneuropathy, it is the most common diabetic neuropathy. D. A patient present with seizure and decreased level of consciousness. Investigations reveal decreased blood glucose and increased insulin levels. So now we are having decreased blood glucose, increased insulin. C-peptide assay done, which shows normal levels of C-peptide. So our patient is having increased insulin and normal C-peptide. It means insulin is not coming from the beta cell. Patient has taken exogenous insulin. So it is not a tumor. It is not possible that patient has taken sulfonylurea, because sulfonylurea increases endogenous insulin. Accidental exogenous insulin administration. Yes, it is correct. Answer is C. A 37-year-old obese woman presents to clinic for routine health evaluation. She reports that over the last year she has had 2 yeast infections, that is fungal infections, treated with over 3 counter remedies. She frequently feels thirsty. She reports waking up at night to urinate. Which of the following studies is the most appropriate first test in evaluating the patient for diabetes mellitus? HbA1c, random plasma glucose, plasma C-peptide, and plasma insulin level. Okay. So now, patient is coming to you in OPD. The time of presentation is not given. Patient is coming to you in fasting state. It is also not given. Okay. Now patient is in OPD. Patient is having clinical features of diabetes. If you check random plasma glucose level and if it is more than 200, then it will be a case of diabetes. So on this spot you will get the diagnosis of diabetes. HbA1c, you have to collect the blood, you have to submit it into the lab, then the report will take 6 to 7 hours or 1 day. So it is better to do random plasma glucose level. Within a 5 seconds you will know what is the sugar level. If it is more than 200, it will be a case of diabetes. Next. A 27-year-old woman with mild obesity is seen by her primary care physician for increased thirst and polyuria. Diabetes mellitus is suspected. Random blood plasma glucose is 211 mg per day. Confirms the diagnosis. Which of the following tests will strongly indicate that she has type 1 diabetes mellitus? Anti-GAD65 antibody, peroxisome proliferator activated receptor gamma 2 polymorphism testing, plasma insulin level testing for human leukocyte antigen. A very simple MCQ from our notes from Harrison. Anti-GAD65 antibody. It is the only commercial test available for type 1 diabetes. It is the only antibody which is commercially available. Okay. Please remember names of all antibodies on, and please remember this anti-GAD65 antibody. And please remember, only pathogenesis can differentiate type 1 from type 2 diabetes. Means if antibodies are present, patient is a case of type 1 diabetes. If antibodies are absent, patient is a case of type 2 diabetes. Then a patient is evaluated in the emergency department for complications of diabetes mellitus due to an episode of life stresses. All of the following laboratory tests are consistent with the diagnosis of DKA except, so please remember they have asked about except. Arterial pH 7.1 acidosis, it is suggestive of diabetic ketoacidosis. Normal pH is 7.35 to 7.45. pH is decreased, means acidosis. Glucose 550. DKA will have increase in the sugar, but sugar levels generally remains below 600. So again, it is a case of diabetic ketoacidosis. Markedly positive plasma ketones, yes, correct. Plasma osmolality of 380 milliosmol per liter. This sentence is not satisfying the criteria of diabetic ketoacidosis. Normal plasma osmolality is 275 to 295. In DKA and in HHS, in both, plasma osmolality increases. In DKA, it increases up to 330, while in HHS, it goes above 330. So 380, it is going with the diagnosis of HHS. It is not going with the diagnosis of DKA. Pick the correct combination of onset of action and duration of action for following insulin. A direct MCQ from the table of Harrison. Okay. Now, aspart is to be glargine and NPH and regular. So which one is correct? You have to remember the most important regular. Regular actions start with 0.5, but it will work for 6 hours. It will work for, it is wrong. Okay. Then GAL GAL, blue lysine aspartame, blue lysine aspartame, blue lysine aspartame. All these three are having duration of action 4 hours. So aspart is having duration of action 4 to 6, and action starts in 15 minutes. Glargine also is having duration of action 24 hours. You can see here, Glargine is having action 24 hours and action is starting in 2 hours. So, correct answer is our Glargine. Aspart, duration of action is 4 hours. So, it is wrong. NPH, duration of action is 16 hours. So, it is also wrong. So, correct answer is Glargine. Action starts in 2 hours and duration of action is 24 hours. So, here you have to remember different insulin preparations with their duration of actions and onset of actions. MCQ number 46. Pick the correct combination of onset of action and duration of action for the following insulin. Aspart, this is glargine, NPH and regular. Now, how to remember this? GAL, glulysin aspart, lispro. All these are short-acting insulin. All these duration of action start at 25 and action duration of action is 4 hours. Okay, so glulysin is not given. Aspart is there. Aspart action starts in 0.25, that is 15 minutes, and duration of action is 4 hours, not 6 hours. Then glulysin is not there, aspart, and then lispro. Lispro is also not given. Then glargine acts for 24 hours and action starts in 2 hours. So it is correct. It is correct. NPH onset is at 2 hours, correct, but duration is not 24. Duration is of 16 hours. Then regular insulin action starts within 30 minutes, it is correct, but duration of action is not 12 hours, duration of action is 6 hours. So the correct answer is glargine. So here you have to remember different insulin preparations with their duration of action and what is the onset of action, what is the after how much minutes action will start. Then 47. A 54-year-old woman is diagnosed with type 2 diabetes mellitus after a routine follow-up for impaired fasting glucose showed that her hemoglobin HbA1c is now 7.6. She has attempted to lose weight and exercise with no improvement in her HbA1c, and drug therapy is now recommended. She has mild systemic hypertension that is well controlled and no other medical conditions. Which of the following is the most appropriate first line therapy? Remember, remember, in patients of diabetes, always the first line drug is metformin, always the drug is metformin, and you have to remember contraindications of metformin. What are the contraindications of metformin? If patient is having increased creatinine level, according to new guidelines, if GFR is less than 30, next if patient is having any acidosis, okay, or if patient is admitted in hospital because of some infection, because of some stress, because for some surgery, because of any case, if patient is hospitalized, then we have to give insulin. Okay, these are the contraindications for metformin. Here patient is not having any contraindication for metformin, so best drug is to start with is metformin. A 24-year-old female with history of type 1 diabetes mellitus is brought to the emergency department with nausea, vomiting, lethargy and dehydration. Her mother notes that she stopped taking insulin one day before. Presentation: she is lethargic, has dry mucous membrane and is often dead. Signs of dehydration is there. Blood pressure is 80/40, hypotension, heart rate is 112, heart sounds are normal, lungs are clear, serum sodium 127, potassium 4.1, magnesium 1.1, blood urea nitrogen 74, creatinine is increased 1.9, bicarb decreased 12, chloride 90, serum glucose is 595. All the following are appropriate management steps except, so MCQ is very important. Patient is a case of diabetic ketoacidosis. All features of diabetic ketoacidosis are given. Now 3% sodium solution absolutely not required in these patients. In this patient, sodium level is decreased because whenever sugar increases, it will attract water molecules from extravascular space, and water molecules they are added to intravascular space. So it causes dilutional hyponatremia. As soon as As soon as we give IV fluid with only normal saline 0.9%, you can correct the sodium. So 3% sodium is not required. Arterial blood gas, yes, it is required, so that we should know what is acidosis and what is the carbon dioxide level in blood. Then IV insulin, definitely, because patient is having 595, sugar level is very high, then this insulin is required to stop lipolysis. IV potassium, yes, even if potassium level is normal, we have to give intravenous potassium because we are giving insulin. As soon as we give insulin, potassium in blood, it will enter in cell and patient will develop hypokalemia, and hypokalemia, it is a risk factor for cardiac arrhythmia and cardiac arrest. So to avoid this, whenever we are giving insulin, we have to give injection of potassium chloride even if potassium levels are normal. Only if potassium level is more than 5.2, then insulin is not required. So here the correct answer is sodium. Okay, 3% sodium solution is not required. A 45-year-old male with type 2 diabetes is evaluated for tingling sensations in hand and feet. He had he has had type 2 diabetes for 10 years with intermittently poor control. His most recent hemoglobin HbA1c was 7.9%. On neurologic examination, there is loss of deep tendon reflexes at the ankle bilaterally. Deep tendon reflexes are 2 plus at the knees and ankle. So loss of reflexes at ankle, then at knee, deep tendon reflexes 2 plus at the knees, not ankle, while biceps and triceps reflexes are normal. Pain temperature sensations are decreased bilaterally to the mid-thigh region and wrist. He also has difficulty in ascertaining if the great toe is being held in up or down position when his eyes are closed. So patient has loss of joint position vibration. He finds it difficult to sleep at night, sometimes due to the pain in the legs. What is the most probable diagnosis? It is a clear-cut case of diabetic neuropathy. Bilateral symmetrical involvement, sensory involvement is there, abnormal sensations are there, loss of joint position vibration is there, sensory involvement, motor involvement is there, reflexes are absent. So it is bilateral symmetrical sensory motor neuropathy. Distal joints are severely affected than proximal, then loss is up to the mid-thigh level. So it is a classical case of distal symmetric sensory motor polyneuropathy, DSPN. Okay, so correct answer is DSPN. A 28-year-old healthcare worker is seen for evaluation of recurrent hypoglycemia. She has had several episodes at work over the past year in which she feels shaky, anxious, and sweaty. She measures her fingerstick glucose. It is 40 to 55 mg per dl. This has been confirmed with plasma glucose level during one episode, 50 mg per dl. She then drinks orange juice and feels better. These episodes have not happened outside the work environment. Aside from oral contraceptives, she takes no medication and is otherwise healthy. Which of the following tests is most likely to demonstrate the underlying cause of hypoglycemia? So now we want to find out the cause of hypoglycemia. First step, measurement of IGF-1. Yes, no. Measurement of IGF-1, it will tell you about the growth hormone. It is a screening test for acromegaly. If growth hormone increases, then IGF-1 will increase. But if growth hormone increases, then glucose level, it will also increase. So it will not tell you about the hypoglycemia. Second, measurement of fasting insulin and glucose. Measurement of fasting insulin, glucose and C-peptide levels. It is very important. C-peptide with insulin. It is best test that insulin with C-peptide. Measurement of insulin glucose C-peptide levels during an symptomatic episode. So now very good options are there. One is asking about fasting. Second is having during symptoms. The best is during symptoms. Okay. I told you in hypoglycemia, when patient is having symptom, then you have to collect the blood and you have to check the glucose. During symptoms, if glucose level is decreased, then these clinical features are because of hypoglycemia. When glucose levels are decreased in normal person, insulin levels should be decreased. But if you are getting increased insulin with increased C-peptide during episode of hypoglycemia, then you can suspect endogenous hypersecretion of insulin. It can be because of drug sulfonylurea or it can be because of some tumor. Okay, so in such patients of hypoglycemia, during hypoglycemia, we have to collect the blood and we have to check glucose, insulin and C-peptide. Now, a 32-year-old female, known case of diabetes, 32-year young female, was brought to emergency department with breathing difficulty, nausea, vomiting, fever, cough. So now it is showing you that the patient is having clinical features of diabetic ketoacidosis. Fever is also there, so stress factor or secondary infection, it is also present. On examination, pulse is 76, BP is also normal, respiratory system tachypnea is present, so we can say Kussmaul's breathing is present. Bilateral air entry equal, no crepitations or spasm, blood glucose level 489, glucose level is increased, it is below 600, it is also suggestive of diabetic ketoacidosis. ECG is shown in the figure. Now, if you see ECG, you can see broad QRS complexes. You can see broad QRS complexes, broad QRS. Then you can see P waves are absent. So you can see P waves are absent. Broad QRS, absent P waves. Then tall T waves. You can see these are the tall T waves. So these features are suggestive of hyperkalemia. So it is a case of diabetic ketoacidosis and having hyperkalemia. Now let us see what they have asked. Which of the following sentence is correct regarding above case? Patient is having lower respiratory tract infection leading to syndrome of inappropriate ADS secretion and ECG is suggestive of hypokalemia. Completely wrong sentence. ECG is suggestive of hyperkalemia. Syndrome of SIADH will have clinical features of hyponatremia, that is confusion, seizure, headache. Okay, it is not the correct one. Patient is suffering from hyperosmolar hyperglycemic state. ECG suggestive of hyperkalemia. Partially correct. ECG is suggestive of hyperkalemia, but patient is not a patient is not a case of hyperosmolar hyperglycemic state. Points against HHS. Age of the patient 32-year-old. Okay, generally the HHS patients are type 2 diabetic patients and these patients are elder one. Next, this patient is having clinical features of diabetic ketoacidosis like breathing difficulty, nausea, vomiting. It is a feature of presence of ketones. Then patient is also having Kussmaul's breathing. So it is also a feature of diabetic ketoacidosis. ECG suggestive of hyperkalemia and in HHS potassium levels are normal. Okay, and sugar levels in HHS, sugar levels are more than 600. Here sugar levels are 489. So it is not a case of HHS. Next, patient is suffering from diabetic acidosis. ECG suggestive of hyperkalemia. It is correct. So option C. Option D, patient is having upper respiratory tract infection and ECG suggestive of acute myocardial infarction. No, it is completely a wrong sentence. A 27-year-old male patient had history of episodes of lightheadedness associated with diaphoresis, palpitations, tremors, feeling of impending doom in past on and off for last 3 years, which were relieved with eating something or taking glucose. At the time of symptoms on examination, his pulse was 120, BP 150/90, increase in heart rate, increase in BP, respiratory rate, it is also increased. His abdomen was soft and non-tender, and on central nervous system examination, patient was drowsy. Blood sample taken at the time of hypoglycemic episode showed plasma glucose 30, insulin 95, normal is 31, up to 31 is normal, insulin is increased, sugar is decreased, C peptide levels are 11. So insulin is increased, C peptide is increased, both are increased. So it is endogenous insulin. Young patient, no history of drug, having recurrent hypoglycemia, and patient is having increased secretion of endogenous insulin, we will suspect a tumor. Endogenous insulin. He was immediately given intravenous glucose and patient became conscious within few minutes. Which of the following will be next appropriate investigation? We will go for CT abdomen to find out the tumor. Serum cortisol, ACTH levels, serum insulin in cortisol, ACTH glucose level will decrease. Okay, glucose level will decrease, but patient will have other features of decrease in cortisol. That is, patient will have weight loss, patient will have decreased hunger. Then urine sulfonylurea level, patient is not giving the history of any drug, patient is not a case of diabetes. MRI brain, okay, it is not important. It is not important in this case.